Right, I'm going to start the morning by talking about the chain of infection, which is a very useful epidemiological model. And it doesn't matter where you work, the chain of infection is useful because you can apply it. Nurses love models. A lot of other groups of people love models as well. I know that not everybody who does this course is a nurse, but the chain of infection is very useful. But what I'd like to say before we really get underway is why we have lectures on this topic. People think that lectures are old-fashioned and that really you shouldn't have lectures anymore. But I like to give value for money, and we can cover a lot of material in a lecture. It's good use of time. We can apply theory to practice and draw out implications for practice for preventing the transmission of infection by things like specimen taking and containing antimicrobial resistance. It doesn't matter if you don't know very much about antimicrobial resistance, because by the end of today, you will. We can be introduced to new information. Very often people who take this course want to take it because they know that they don't know an awful lot, or they know that there are gaps in their knowledge and they don't really know what they don't know. They don't know where to start. So formal lectures are very good for that kind of thing. And the reassuring thing is that these lectures are prepared for people with no background in microbiology. It doesn't matter if you start off knowing nothing, because these lectures are designed for anybody from any kind of background. I spent a lot of my life teaching science to people who don't have a background in science. My own first degree is in natural sciences, botany and zoology. And it's important to be able to learn to think as well. You'll get to see a lot of information on these slides, and you won't want it all, and you won't remember it all. And that's fine, because nobody is going to set you an exam on it. So you don't need to worry about that. But you do need to learn how to think. And we have lots of guidelines in infection prevention and control. We have a guideline for every single thing that you can think of, but guidelines still can't cater for every eventuality. That's one of the things that the pandemic taught us, that the country wasn't very well prepared and people had to think for the first time, and there were big gaps in what we were prepared for and what we knew and what we could do practically and in theoretical terms. And so a guideline is all very well, but it's what you do with the guideline that matters. But also we can share experiences and we can be entertained. And I think that lectures can be very, very entertaining indeed, and a very nice way to learn. And we try to be as interactive as we can, remembering that this is distance learning. It does have drawbacks, but we can make the most of it. So they're the main groups of microorganisms I'm going to present to you. Microorganisms, the ones that cause disease, we call pathogens. A pathogen is anything that causes disease. And the main groups of organisms that cause disease are bacteria and viruses, fungi, protozoa, a group called mycoplasmas, the Rickettsia and the Chlamydia, and the bottom parasitic worms. And I put in brackets that when we talk about parasitic worms, we don't usually talk about infections. We tend to talk about infestations. We don't say that people are infected with a tapeworm. We say that they're infested with one. So today, after the chain of infection, we're going to concentrate on bacteria, and tomorrow we'll concentrate on viruses and say a little bit about the other groups and notable pathogens in them that cause infections. So the chain of infection is an epidemiological model that can be applied to all pathogens, all agents that cause disease. It probably originated in the US, and it would be nice if I could say that such and such a person first thought of this model, but actually I can't. Nobody seems to know where the idea came from. It first seemed to arrive in the UK in Bristol. I don't know why, but a lady called Betty Bowell used to work in Bristol. She was very prominent in infection prevention 20, 30 years ago, and she was the person who used to talk about it a lot in conferences. And she was a very lovely person who was very generous with her time. When I was doing my PhD, she looked at all the interview guides and all the other things I was going to use and commented on them. And she was very, very good. And I would like to think I can be as good to other people as she was to me. She's not with us any longer, I'm afraid. But the chain of infection consists of a series of events that are necessary for pathogens to spread. And it describes the interaction between the pathogen, the host, and the environment. And each part of the chain can be conceptualized as a link. And understanding the chain and the links in it enable us to introduce infection prevention and control measures at appropriate times. And if we do that, then we can break the chain of infection and we can prevent transmission occurring, and we can prevent infections happening. So infection can be prevented by breaking any link in the chain. Now, this diagram doesn't come out particularly well on a slide, but that doesn't matter very much because you can call it up easily on Google. You can go into the RCN website and call it up. So it looks rather like a Christmas tree decoration, those sort of things you used to make in primary school. But at the top, you've got microorganism, the reservoir, the portal of exit, the way that the germ is spread, the portal of entry, and how it gets into a susceptible host. And we'll go through all of these things in stages. So there are the 6 links: the reservoir, the portal of exit, the mode of transmission, the way that the pathogen gets into its new host. It's got access a suitable site in the host. It's got to be able to invade, and it's got to be able to interact with the host and then cause infection. Now, the reservoir is where the pathogens live and where they multiply. And one of the reservoirs that there is for infection is people. When we talk about people, we talk about patients in a hospital, we talk about residents in nursing homes and in hospices. People include staff, they include visitors, and the reservoir is the source of infection when we're talking about the classic communicable diseases, particularly those of childhood, mumps, measles, chickenpox, and also influenza. The source of infection there, where infection is stored, is the reservoir. I've put an asterisk there because remember that people can be infected. You can see if they've got a cold, if they've got viruses coming out of every orifice, you can see they'd be showing symptoms. But remember that some people can be asymptomatic carriers. That was one of the big concepts that emerged from the pandemic, that people hadn't realized before, that you might not have any symptoms of infection, but you could still be spreading it because you could be incubating the infection, but not know that you've got it yet. You could be recovering, or you could be very mildly infected and never even know that you had been ill. So those people might nevertheless be infectious. The reservoir could be an inanimate surface, a contaminated surface, an object. An object that transfers infection is called a fomite. There are some words in infection prevention and in medical microbiology that you have to remember and that you have to get your head round. Some people present students or people listening to lectures with lists of words they need to think about and bibliographies. I don't like to do that because I think it's boring. I try to introduce the terminology as we go along, and that's usually all right for people. If you work in healthcare, you'll be very familiar with fomites, bedpans, bedclothes. If you work with children, toys. I've got a friend, a colleague, who works in a children's hospice. So I know quite a lot about what goes on in hospices, especially children's hospices. And of course, toys would be the obvious fomites there. Bedside curtains are often a very underestimated source of infection. Many of the healthcare-associated infections come from inanimate surfaces. Some infections are stored in the environment, soil and water. Tetanus, the source of that is in the soil. Legionnaire's disease in water. And these are infections that we'll talk about later on. An infection that comes from animals is called a zoonosis. And obvious ones will be rabies, rabid dogs. Lassa fever, you probably don't know the reservoir infection there. In Africa, where Lassa fever comes from, the reservoir of infection there is a small rodent called the multimammate mouse. I know quite a lot about Lassa fever because many years ago, when I worked in practice as an infection prevention nurse, somebody came into the hospital and was there 3 days and thought they had malaria before we realized that they had Lassa fever. Ebola fever is also a zoonosis, so is Lyme disease. Lyme disease is tick-borne, and a lot of the exotic emergent infections that we read about from time to time, Zika virus, for example, is the reservoir there is mosquitoes. So the pathogen has to escape from the reservoir, and it can do that for contact from one surface to another. And the health worker's hands is a major source by which infection escapes from the reservoir, which is why we place so much emphasis in infection prevention on hand hygiene to break the chain of infection. My own PhD from many years ago was looking at hand hygiene, which was then and still is considered to be very important. Respiratory viruses escape from the reservoir in coughs and sneezes and spluttered speech, and increasingly we're becoming aware in ordinary breathing as well, exhalations. The enteric pathogens escape in vomit and feces. Pathogens can escape on skin scales, in dust, blood-borne pathogens in blood and body fluids, and also a portal for pregnant women across the placental, the transplacental or vertical route of escape. So the mode of transmission is how pathogens are spread by direct contact between surfaces, by direct contact on hands and fomites, objects that are able to transfer infection. Infection may be airborne or spread by the droplet route, and we'll talk about that in a minute. And contaminated food and water also transfers pathogens. Salmonella, cholera, and typhoid are examples of pathogens that are spread by that route. Some infections are spread by insect vectors. You'll be probably aware that malaria is spread by mosquitoes, and we call that biological transmission. The organism that causes malaria, Plasmodium, lives inside the female mosquito. I don't know why it's the female mosquito, but it is. And it has a complicated life cycle within the mosquito, which I'm not going to explain to you because you can know a lot about malaria without having to worry about that. But also spread can occur mechanically from parts of the insect or parts of the creature directly. Houseflies don't have a complex relationship with pathogens that they spread. They walk in something dreadful, they pick up germs from that, and then they walk on a surface like food and transfer infection that way mechanically, or they can feed, they can be attracted to open wounds, and that is a possible way of spread. The airborne and droplet route was a topic that was previously neglected. This is a route of transmission that has received really very little attention from medical microbiologists and infection prevention specialists. Research has gone on since the 1940s, but not very much of it, and not very well disseminated infection. And a lot of infection prevention people don't know very much about it. And this became apparent during the pandemic because much of this research is done not by medical microbiologists at all, or infection prevention nurses, but it's done by biomedical scientists and mathematicians. In this country, somebody called Clive Beggs has done a great deal of work in this sphere, but he's the only person I know who actually has 2 PhDs. He sounds like a marvelous person. I've met him on Zoom to talk about his research, but a lot of it is not available. If you want to get hold of this research, you can get hold of it. The RCN library will get hold of it for you, but it's not kept in journals that this library stocks. So there's a lot that we still don't know about this route. Knowledge is emerging, and what we do know, we're not using enough because there's a huge amount of contemporary interest in this route. And the impetus, of course, came from the clinical implications from the SARS-CoV-2 virus, which caused COVID. And the clinical applications there are for mask wearing, respiratory protective equipment, PPE, and social distancing. And that will be very important for future pandemic planning. Mechanisms for respiratory spread by respiratory secretions, there are 2 ideas. One is a very traditional idea, which we think now is outmoded, and there's a modern view. There are 2 distinct, years ago, and even now, people talk about there being 2 distinct routes of spread of respiratory secretions. Once it was thought that there was a distinction between droplets and aerosols. Droplets were thought to be very large drops, over 100 micrometers in diameter, so they can be they are quite large. They're expelled during coughing, singing, speech. They're projected into the air when somebody has a very spitty speech, or they cough or they sneeze. If they reach somebody's mouth or nostrils, if you've got the misfortune to be bending over somebody within close range, for example, a child that isn't yet socialized, they settle under gravity, they contaminate surfaces and fomites, and people think that if you touch the droplet, then you get the transfer to your mouth and nostrils. The conjunctivae are the membranes that line your eyes, and biologically they're the same as the membranes that line your nostrils. So colds are transmitted by rubbing eyes. So droplet transmission certainly does occur. Aerosol transmission occurs as well, but aerosols are much smaller droplets. They travel long distances. They can remain suspended in the air for hours, and they can be inhaled through the mouth, the nostrils, and deposited on the conjunctivae. And this accounts for the fact that people can say, well, I don't know where I got this infection from. I haven't been near somebody who obviously has an infection. Probably they haven't, but they came into contact with aerosol spread. Measles is known to be spread by the aerosol route, and measles can travel through the air for very long distances. Indeed, when I was a child, of course, I hadn't been inoculated against MMR, against measles, because I'm too old. We lived in a tiny hamlet in the middle of nowhere, and I developed measles in the middle of the school holidays. There were no other children in that hamlet. So those aerosols must have got to me from a long distance. But what is old-fashioned is that people think that there's a cut-off route between droplets and aerosols, but in fact, probably the one can transfer into the other. So the contemporary theory is that when you breathe out, when you exhale, what you breathe out contains large numbers of particles, and they're different sizes. There are droplets in there, and there are aerosols. The droplets fall under gravity, but the other smaller particles travel for much longer. And some of the droplets dry out and begin to form aerosols. And so there's no distinct cutoff between the two. It tends to be that droplets tend to be generated from the upper respiratory airways, and aerosols tend to come from the lower airways. Colds tend to come from the upper respiratory airways. If you have a cold, it tends to affect your nose. Your nose gets very gunky. People tend to touch their nose a lot. Their surrounding environment becomes very heavily contaminated, and so do the things that they touch. Aerosols tend to be generated much lower in the respiratory tract. COVID comes from deep in the respiratory tract. So does influenza, and so does TB, tuberculosis. So airborne and droplet spread, coughing and speech and breathing releases a cloud of droplets and aerosols of different sizes. The force of the cough or the speech propels that cloud forwards. If you want to see it, then try breathing out on a cold morning, like the kind that are to come in this country very soon. And you'll see your breath, and you'll see droplets of all sorts of different sizes traveling forward. The droplets are kept moist in the cloud. They evaporate at different rates depending on their size. The heavy ones fall to the ground, and then direct and indirect spread comes when people touch the environment around themselves. The smaller droplets travel a long way. They're said to be able to travel up to 8 meters, but they can probably travel much further than that. The length of time they survive depends on the ambient conditions, the surrounding conditions. Humidity, pathogens tend to survive longer, and they tend to survive longer in a suitable temperature. And airflows disrupt spread. That's where good ventilation becomes very important. Ventilation reduces the risk of infection, which is why, of course, we should have good ventilation in premises where healthcare is delivered, although often we don't in the UK, and why in operating theatres, airflow is paramount, and there are guidelines, very strict guidelines, and legislation that talks about how rapidly you have to replace all the air in an operating theatre. And if that's where you work, if the ventilation breaks down in a theatre, then you know that that is when you're going to get infections. So we can't allow that to happen. If we look at this slide, which I pirated from the Journal of Hospital Infection, if you really stare at it, the large particles are a bluey-grey colour, and the red dots are the smaller, the aerosol spread. And you can see that the large droplets fall to the floor. Those two people that are leaning all over one another are very likely to contaminate one another with large droplets, whereas the person standing further away, aloof, is much less likely to get droplet spread infection, but they're still at risk from aerosols because the aerosols will remain airborne for much longer. Many pathogens are spread by more than one route. So there are several routes which spread them, and protection has to be multi-layered, particularly if it's spread by the air. So for an airborne infection, physical distancing can do so much. Face protection can help. Hand hygiene, in the case of droplet spread, can help. And if immunization is available, then of course immunization. But immunization, of course, isn't available for all infections. When we talk about infections these days, people, because of this difficulty, because people still tend to distinguish between droplets and airborne infections, the new term that people talk about is through the air infections. That's rather a mouthful, so I'm not sure how long we should be saying that. But at the moment, if you want to be in vogue, you talk about a through the air infection. And here are some examples of through the air infections. Measles is spread by aerosols. It is deep in your lungs, deep in the airways. Everybody is familiar with the R number, the number of people that will be infected if we think there's an infective source. People were very familiar with this during the pandemic, and they would talk about the R number in relation to COVID, and they would worry when it was over 2, and they would worry when it was 3 or 4, but all things are by comparison. Measles is highly infectious. The R rate for measles is 18 on average, much, much higher than for COVID. Varicella is the fancy name for chickenpox, and it's spread in aerosols, but also in the vesicular fluid of the lesions that people get. It's usually a child. TB is spread by aerosols. The common cold tends to affect your nose much higher in the respiratory tract and to be spread by droplet. Norovirus, the organism that is responsible for winter vomiting, is spread by droplets, but you don't tend to breathe them in, you tend to swallow them. Norovirus is spread by direct and indirect contact and by contaminated food as well, from bivalve shellfish, that is, shellfish like mussels, mools, and cockles that have got 2 shells, not from crustaceans, things like lobsters and prawns. We're going to talk about norovirus in detail later, and we'll talk about the other ones in detail later too. The portal of entry is the way that the pathogen gets into the host tissues of the new host, and they can be inhaled. Colds, flu, the classical diseases, communicable diseases of childhood, measles, chickenpox. You can ingest a pathogen, food poisoning. There are 2 sorts of food poisoning. There's intoxication and there's genuine infection. Intoxication occurs when you swallow the toxins. If you have a toxin-borne food poison, then the toxin isn't infectious and you can't catch it from another person. Polio and cholera are examples of where you ingest a pathogen. The urinogenital tract, urinary pathogens, and sexually transmitted diseases. When I was much younger, I worked in a clinic for genitourinary infections, and so a lot of the examples that I give are to do with sexually transmitted disease. And because I spent a lot of my life teaching young people who are 18 to 21, who are very ghoulish and who love hearing about sexually transmitted disease, a lot of my examples are about that, because they wake people up and engage people. Another portal of entry is inoculation via the skin and mucous membranes. The obvious thing there is surgical site infection and needle stick injury, which is such a big occupational hazard for us. Vertical transmission occurs from the mother to the baby. It can occur from the placenta, from the maternal to the fetal circulation. Congenital syphilis falls into that group. Contamination can occur as the baby goes down the birth canal. Gonorrhea is spread vertically in that way, from the mother, from an infected birth canal to the baby's eyes. I have seen that once in my life only, and that was very shocking. Seeing a little baby with pus coming out of their eyes. I never want to see that again. That was very shocking and preventable. And vertical spread can occur via breast milk from varicella, from a mother who's got shingles. We'll be talking about shingles later as well. So if you do miss some of this, you can always listen to the recording, but we will enlarge on these examples later. We're not just going to talk about them now and forget about them. And there's also interaction between the host and the pathogen, which can be very complex. And a lot depends on the immunity of the host, the size of the infective dose, and how virulent it is, how able to cause disease it is. Host immunity can be innate, and it can be species specific. People always say, well, the common cold causes a great deal of misery, especially in our damp climate, especially in the winter months, and almost no research has gone on about it. Maybe one of the reasons we don't know very much about the common cold is because we're all going to get better anyway, in the end, even if it does affect the economy in schools, because people feeling too poorly don't perform very well. But another of the reasons why we don't do very much research in colds is that the human cold not a lot of other creatures don't get colds. If you've got cats or dogs, many of the infections that they carry, you're not going to get yourself, but they're not going to get a cold or a cough from you. But the laboratory animal that does catch a cold is the ferret. But ferrets are not very user-friendly animals, really. Ferrets tend to bite. And so they tend not to be used very much. At one time, I had a fancy to have a ferret, but my husband said, no, we've got 3 cats, we've got enough, and we could cope without a ferret, even if it was possible to house train them. So I never managed to persuade him there. But ferrets do catch colds, but a lot of people are not keen to keep a ferret. Men are generally more susceptible to infections than women. Men generally succumb to illnesses more than women do at any stage throughout the life cycle. Women tend to survive longer than men. They have a longer lifespan, and at any stage in the life cycle, for a variety of reasons, women's general health tends to be better than that of men, but men are more susceptible to infection. It seems to be something that is innate in them. And then for many infections, genetic inheritance does play a role. Sickle cell disease tends to help people to be immune from or to be resistant to malaria, and develops in people who live in parts, indigenously, in parts of the world where malaria is endemic. And the same is true of thalassemia. But for many other infections, there does seem to be a genetic factor at risk. If somebody in your family has TB, even if you're geographically separated from them, your risk of getting TB seems to be higher. I'm not trying to persuade you that TB is a genetic disease. Obviously, it's not. But if somebody in your family is susceptible to TB, then your susceptibility is increased. And the same tends to be true of HIV and malaria as well. Evidence comes from twin studies. People have done studies on children who are genetically identical. All their genes are in common. They look exactly alike. And there are rare cases where twins are brought up apart. And although they barely remember even that they had another twin, it seems that many of the characteristics that they have, including to susceptibility to infection, seems to be something that they had. I used to teach genetics because nobody in King's College was willing to teach genetics to nurses and midwives on Friday afternoons. So even though I don't particularly have, or I didn't at the beginning, have a great deal of knowledge about genetics, I ended up with one. And we used to talk about twin studies then. And I used to have a lovely genetics book which showed pictures of 2 old men who were separated in Nazi Germany when their families had to escape from the Nazis. One family escaped somewhere else in Europe. The other part of the family escaped to the States. And in late middle life, these two men didn't even speak the same language. The one in Europe spoke, I think, still spoke German. The one who went to the US spoke English, but they both became professors of zoology. And their pictures, their photographs in the journal shows not only that they looked exactly alike, they both grown a beard, which made them look alike, and they both smoked a pipe. And they both become professors of zoology. So we can learn a lot from twin studies, but we can't do them very often because twins are relatively unusual, and for them to be brought up quite apart from one another is very rare. But a lot depends on the individual's immune system. So we can have acquired immunity. There's a bar going along the bottom there. Thank you. We're just adjusting the slide here. Lovely. Acquired immunity can be active or passive, and we're going to talk about both. So there are different sorts of acquired immunity. Active immunity is immunity that's acquired throughout your lifetime. Natural active immunity is when antibodies develop in response to exposure to the infection. Before we had the MMR vaccination, people developed measles and mumps antibodies and rubella antibodies naturally through exposure to other people who'd had those infections. And that's what I have because I'm old. But artificial active immunity is what you're going to have if you've been vaccinated. So after the MMR was introduced in about 1968, people didn't catch these infections so much anymore. I'm afraid they still do if they haven't been vaccinated, but hopefully that should be a thing of the past because we have the technology to prevent it. Passive immunity occurs after somebody receives components of the immune system from another person, often to give short-term protection. Natural passive immunity occurs when the baby gets antibodies from the mother via breast milk, which is one of the reasons why people say breast is best. We quite often get midwives coming on the course, and measles antibodies the baby gets them that way, and they are protective for as long as the baby is fed. Artificial passive immunity occurs usually somebody is given it after they've had an exposure to an infection, after exposure to hepatitis B, after an animal bite from an animal that might be carrying rabies. People are given gamma globulin, which gives them temporary protection from the infections. There are different sorts of vaccines as well. We call them live attenuated vaccines. Viruses can't really be alive, but we call them live because they contain a weakened form of the organism. The MMR is like that. So is the smallpox vaccine, and so is the chickenpox vaccine. There is a vaccine for chickenpox. Many people don't realize that there is, but there is. It's only recently been licensed in this country. Inactivated vaccines are those that have been exposed usually to heat or to radiation. A hepatitis A vaccine, flu vaccines, polio and rabies belong to that group. Then there's a group of vaccines that are made from parts of the organism which on their own can't cause an infection. So they're called subunit or recombinant vaccines. The ones that you'll be familiar with are hepatitis B, pneumococcal disease, streptococcal infection is the vaccine is like that. The manufacturer that produces a lot of pneumococcal vaccines in this country is Pfizer. And during the pandemic, I did quite a lot of the literature reviewing and work on pneumococcal disease for Pfizer. The meningococcal vaccines are like that too, and herpes zoster. The toxoid vaccines are ones that are made from the toxins caused by organisms. Diphtheria and tetanus fall into that group. So I'm just going to have a drink here because my throat gets scratchy. So herd immunity, people heard a lot about this again in the pandemic. Herd immunity is resistance to infectious disease within a population based based on a pre-existing immunity. So if a lot of people in a community, a lot of people in a population are immune from an infection, then the people who haven't become immune to the infection are protected because they won't physically encounter that infection very easily, because pathogens are parasites. All parasites must be adapted to their host. A good parasite doesn't kill its host. It lives alongside it, inside it, if it's a very successful pathogen. And so if 90% of us are immune, the remaining 10% are going to be protected by the rarity, the unusualness of coming into contact with somebody who's infectious. And herd immunity can be achieved either naturally through natural exposure, or it can be artificially introduced through vaccination. And the outcome is that it protects not just immunity to the individual, but it protects the exposure of everybody. And if we apply this to vaccination programs, then the population is protected from a given pathogen once we reach a particular threshold of vaccination. And by a rule of thumb, if 80% of the population, if 80 out of 100 people are protected, then 4 out of 5 people who come into contact with the encounter probably won't be infected. But a lot depends on how contagious the pathogen is, and pathogens vary in their virulence. There are some circumstances when herd immunity is very difficult to achieve and can't really be achieved. It's not really our aim. We're really talking about protecting the individual, or something goes wrong and we don't get protection. Herd immunity isn't achieved if uptake of the vaccine is poor, and we know that that is a problem very often in this country, but in many other countries as well. Uptake of MMR particularly tends to be poor. People tend to have doubtful views about it, which we'll discuss later on in these couple of days. When I was developing these lectures, I was still working at Cardiff University. I was working at Cardiff in 2012, 2013, when there was a big outbreak of of measles in Swansea. And there were 664 cases, 8 people were admitted to hospital, and 1 person died. And that was not somebody with pre-existing disease either, but a young man with no pre-existing evidence of disease at all. He was 25 years of age. Many people don't realize that they're not protected. At the time of this outbreak in Swansea, we had a research assistant who worked in the department called Tom. And Tom's parents phoned up. They didn't live in Wales. They phoned up and they said, "Now about the MMR." And Tom said, "Of course, all children are vaccinated, are up to date with their MMRs, mum and dad. Don't be silly." And his parents said, "Yes, but you are not. When you were born, it seemed that you weren't very well, and we were advised not to get you vaccinated. And so you're not protected against measles. You better go and be vaccinated quickly." He had no idea that he wasn't. So, you need to be aware of your personal status. It may surprise you. In some circumstances, the organism that is causing the infection may change. Viruses mutate. They change all the time. Viruses, particularly the flu virus, undergoes what we call antigenic drift and shift. It changes slowly all the time, and occasionally it has a sudden change in the antigens that are present on its surface, which is why people need a flu injection every year in order to gain immunity. Flu vaccination doesn't give complete immunity because there is always more than one strain of flu about. In 1999 to 2000, there was big outbreaks of flu in the UK. We didn't quite reach outbreak levels, but number of cases was higher than usual, and there were a higher number of GP consultations, a higher number of people admitted to hospital with flu, and morbidity and mortality from flu were higher than usual. I was one of the people who developed flu. I was working at South Bank University at the time, and I know jolly well that I got it by visiting the research department that helps you develop your research bids to get money. They work out the budget for you. I went there to have my budget worked out for me, and I came back with flu, and I was very ill. Everybody was worrying about the millennium, and the millennium doing damage to your computer. I couldn't care a fig because I don't remember much about Christmas Day that year. Afterwards, my husband said to me, "Oh, you were really ill, Mrs. Gould. You were very ill. I've never known you be so ill. You didn't tell me off. For 3 whole days you were so ill." I was so unwell that my mother phoned. My mother was alive then. My mother phoned every day for a week. I didn't even become irate. You can tell how ill I was. People think that flu and a cold are the same thing. They are not. Pathogens might not be spread directly from one person to another either. Tetanus is spread in soil and in water. But if I have tetanus, you can't get it from me. The tetanus vaccination is for personal protection only. And herpes zoster, shingles, is the same. The virus tends to remain dormant in the neurons, the nerve bodies of your body, and becomes reactivated if you're not very well. The vaccination can prevent that happening, but it's for personal protection only. If I have shingles, you will tend not to be able to get it from me unless you get in contact with the actual fluid coming out of the lesions. But immunity, we're not talking about herd immunity for shingles. Things that determine immunity are the extremes of life. Very young infants, well, infants are very young, that was a silly thing to say, but very young children are at high risk of infection, and advanced age. People's immune systems tend not to be so good, although some people's are better than others. Effect of chronic illness, malignancy, anemia reduces resistance to infection. Invasive devices bypass the body's normal defenses to infection. So having intact skin is the greatest protection that you can have. Medication can be immunosuppressive. Chemotherapy is an example. Pregnancy has an immunosuppressive effect. Otherwise, you couldn't carry the baby. Being malnourished. You hear of terrible outbreaks of measles and other infections affecting children from low-income countries where vaccination isn't available to people. And that's because a very high proportion of the population is malnourished, especially children. Dehydration increases risk of infection, oral infections and urinary infections. Living conditions, overcrowding, poor living conditions, increased risk of infection, and semi-closed environments do. Schools and prisons are examples of semi-closed environments, but they don't necessarily have to be poor. Cruise ships tend to be the sort of things that affluent people go on cruises, but people on cruises are holed up together, and below the waterline, all the people who look after you are in cabins, and they're all in cabins together. And so infections on cruise liners are a major risk factor in that industry. I know that because my husband worked for a cruise company before he retired. And remember, of course, that people's immunity can change over a lifetime. It can change naturally as people get older and then get very old, and according to what they've been exposed to and vaccinated against. The size of the infective dose and exposure to it are also important. It's axiomatic that the bigger the sneeze, the bigger the cough, or the bigger the mouthful of contaminated food or water you have, the more likely your immune system is going to be overwhelmed. Often it's very difficult to get sputum out of somebody with TB. They've got tuberculosis. Theoretically, they're infectious, but the risk of infection comes from exposure to the sputum. And it's really difficult to get sputum out of somebody, and you've got to enlist the help of the physio to do it. The physio is going to be a great risk trying to do that because it's an aerosol generating procedure. But if there's not very much sputum, then people who are not in the direct line of it, they're probably at much less risk. And of course, you should be immunized anyway. Frequency of risky behavior is important as well. If somebody has lots of sexual encounters, then we test them for the full range of sexually transmitted diseases, because if they're at risk of one, then they're at the risk of the lot. There are situations when risk of infection is increased. High pressure of work, when people cut corners, is one of those things. Things are problematic then. Movement of staff between wards, where health workers are peripatetic, where they go from one location in the hospital to another, they can transfer infection then, or moving patients between wards and across sectors. We do this quite a lot in the UK, I think more than in many other countries. I was once involved in a big project that was funded by the European Union, and I realised then that we go in more for ward transfers in the same hospital than many other countries. If you get to know what goes on in other countries, somehow it seems to, you learn more about your own. You think that what goes on in your own country, your own field, is what's usual, and then you're enlightened when you hear other people have got other ways of doing things. But we move people between the accident department when they're admitted to an acute ward. They move them to a long stay ward. They then move them to a nursing home or to a hospice, or we may move them home and have the district nurse visiting them or whatever. And wherever somebody goes, they carry their pathogens with them. Super spreading cases is where the index case, the first case, is very heavily infected, and they're very likely to infect other people because they're producing so much of the organism. And risky behaviors, uninhibited behavior, when people have a devil-may-care attitude, people who are excited, who are drunk, emotional situations. Early in the pandemic, ski resorts were a major source of COVID right in the beginning, because people were excited, they'd had a good day on the slopes, they tended to have a good drink, and they tended to get loud and noisy in bars, and overcrowding in hospital rooms. You often hear about wartime and how people in wartime were uninhibited. Lots of people leapt into bed with one another because they thought it was their last opportunity to do so. So the rates of sexually transmitted infection were very high then. And also troops moved about. So there are situations where people's inhibitions are lowered. We tend to get a very high risk of infection. So behavior has its implications for infection as well. Virulence is the ability of a pathogen to cause disease. And virulence is a measure of the severity of the disease that is caused. Severity of infection is greater if the pathogen is very highly virulent and if the potential host gets a great big dose of the microorganisms. Virulence factor is the property of a pathogen that increases its ability to enter the host. Some pathogens get in easily. It's easy to catch cold because all you have to do is breathe it in. Actually, it's quite hard to get HIV or sexually transmitted disease because you've got to engage in very specific behavior to get it. HIV is not that easy to get, not really, because it's particular modes of spread. Virulence also depends on the ability to colonize the host. And microorganisms, pathogens, are designed in different ways. Neisseria gonorrhoeae, which causes gonorrhea, as you can tell from its name, is covered with little hair-like processes called pili. An artificially produced Neisseria gonorrhoeae that doesn't have pili doesn't cause infections. TB, caused by Mycobacterium tuberculosis, has got a very thick coat. It withstands the actions of the host immune system, white blood cells, very well. It walls itself off from the rest of the lungs very well, and that's why it causes very chronic infections that are difficult to treat. Some species of E. coli, Escherichia coli, which causes urinary tract infections, have a very thick mucousy coat. Those ones are able to bind to the urogenital tract very easily and cause urinary tract infections much more easily than other strains. So different strains of bacteria and viruses behave in different ways. The host response is important as well. Toxins that some pathogens are covered with toxins that prevent the white blood cells engulfing the pathogen. Phagocytosis, if you remember from basic physiology, is a process whereby your white blood cells eat any germs they encounter, and some pathogens are designed to try and evade white blood cells. And some organisms develop antimicrobial resistance. Some organisms produce enzymes that kill or enable them to have resistance against particular antibiotics. And many gram-negative bacteria, anyway, have got natural resistance. The carbapenemase is a group of enzymes that many gram-negative bacteria produce. E. coli and Klebsiella produce these enzymes, and outbreaks of these antimicrobial bacteria are responsible for very big outbreaks and global and this is becoming a global problem. And this is what Chris is going to talk about in her next lecture. Now we're more or less on time here. That's magic. It all happens by magic. The information in this lecture is supported by the virtual laboratory that Chris mentioned, which I hope at some stage you'll look at. I think I didn't invent the virtual laboratory, but I think it's wonderful because you can see the workings of a laboratory and you can learn such a lot just by sitting in your chair looking at a computer without having to go anywhere special. I used to have to take my classes to the laboratory to see what was going on in the laboratory. And if it was very busy that day, they would say, we don't want you, you've got to go back to the university. And I would be left there with a class of 30 people and not know what to do with them. So I think that being able to ask somebody just to look at something from a chair at home is wonderful. And there are other course resources. Parts of the learning platform have got special podcasts and pre-recorded lectures about specimen taking and immunity, which I know you can look at in your own time, or this lecture is being recorded, you can always go back to it. There are information sources to do with infection prevention that are official. The World Health Organization gives us a global perspective on infections. The UK Health Security Agency, which used to be Public Health England, that I think one person here works for, is a source of a lot of information. The Infection Prevention Society produces educational materials. So does the Centre for Disease Control, CDC, which that comes from the States, but you can get into their materials free of charge, and the World Health ones on your computer. The Society for Healthcare Epidemiology, SHEA, and APIC, both organizations from the States, but you can access their materials to help with your written work if you want. You can get into any of it free of charge. And also the European Society of Clinical Microbiology and Infection, and ECDC, the European Centre for Disease Prevention and Control. You don't have to belong to these societies to get hold of their materials, and their materials are very good. The media produces information about infection prevention, but you've got to be much more wary about this. It's played a big role in informing the public for many years about infections. People in the high days of MRSA, people learned a lot about MRSA from the press, which often described it as a potent virus, when of course it's a bacterium. There was a lot written about MRSA in the newspapers and a lot on the radio, but you used to hear much less about C. diff and read much less about it in newspapers and hear much less about it on the radio. And I once asked a journalist why this might be, and she said, oh, it's simple. MRSA doesn't smell, C. diff does. And people don't want to hear about vomiting and diarrhea when they're eating their breakfast anyway. So that's what that affects what we read. It's very simplistic, but it does. But then there are ongoing problems, things to do with fake news in the press. In this spring, there was an article in quite a lot of the broadsheet newspapers about an organism that caused an outbreak of contaminated eye drops in India, Burkholderia cepacia. 52 people were infected in April 2024, mostly in India, and the Deadly Telegraph described Burkholderia as a deadly bacterium. Actually, it very rarely causes infection in anybody who's fit and healthy. So this infection in people is very rare. Newspapers, the media, can be a source of fake news, and it can give rise to public concern and a lot of worry that is a storm in a teacup. So what's next? Chain of infection is a very useful model. To maximize use in clinical practice, we need to be able to have examples to plug into the model. So we're going to look at a range of pathogens, bacteria and viruses and other organisms. And after each lecture, we'll apply the model with opportunities to try it out. So here we are, here's a halfway break, and Chris is going to speak next. Thank you very much for listening so far.
Perfect. So the session that I'm going to run for you now is called An Introduction to Infection Prevention and Control. Just share my screen with you, get that all working. Okay. Just bear with me while I sort my windows out. Okay. I'm hoping that all of you can see the screen now. Yes, thank you. Thank you for nodding, Nikki. I spotted that. That's great. Thank you. So what we're going to be doing in this session, we're going to look at the contemporary context of IPC in the UK and look at it internationally a little bit as well. We're going to look at some of the political drivers that have influenced IPC. And we're going to look at the link between IPC and antimicrobial resistance. And hopefully you'll get an appreciation of how you will be able to gain an awareness of how IPC local actions impact on the broader national context of what we're doing with IPC as well. So why is infection an issue? And we're thinking now pre-COVID-19. And prior to that, infection had been thought about that it was mainly in health and care settings. And certainly at the beginning of my career in infection prevention and control, most of it was thought about of how it happened in hospitals. Care and nursing homes were not included quite so much, and healthcare that occurred in the community was not included quite so much. And I think that probably also was because most of the significant interventions happened in a hospital setting. And the landscape has changed dramatically in that period of time. When we first opened the Children's Hospital in Bristol, which we're going back now about 25 years or so ago with that, they designed the intensive care unit for a certain number of beds. And at that point in the Southwest, we probably had a handful of children that were on ventilation in the community. And if they needed to come in and out of hospital, we would have had a side room for them to come in while they were in intensive care unit. Now, when you think of the number of people in the community that are on home ventilation, I'm sure we probably all know somebody who's at home having feeding through a PEG tube, especially those of us that work in those settings. It will be normal. So we didn't think of those infections at that point in time as being related to what occurred in the community. Now we do, and clearly COVID has taught us a little bit about the fact that we need to think of transmission of infections in community settings sometimes as much as we need to think about their transmission in hospital settings. The other thing that the Children's Hospital taught me as well about transmission of infection is when you've got children, they're not little adults when it comes to IPC. You've really got to think differently, because we would have had families that were staying in the hospital accommodation that would have been communicating together. So when you've got things like a norovirus outbreak, we weren't just looking at what happened in the hospital. We had to think about what was happening in their accommodation as well as what was happening on the hospital wards. We've got infectious diseases now that are different to what we would have had a while ago, and that are important ones to us to think about in the hospital settings. And we've got the resistance to treatments that is happening with antimicrobial resistance, which we'll talk about a little bit later. And then we've got infections that have international significance, and the fact that the world is now, to coin the frame, a global village. And with air transport, we can be around the world in a short period of time. So infections will transmit a lot faster as well. But we know that infections cost money. We know that they can be an indicator of the quality of care in a healthcare setting. And we know the prevention of infection is still as important now as it was, if not more, than when I started my career in healthcare in 1979. So let's look at what information we have. Now, this is quite old data now. And it's from the previous Health Protection Agency survey that was done in 2011 and reported in 2012. Now, we know there's currently the point prevalence survey that's taken place in the United Kingdom. The data's been collected and we're still awaiting the results. Last time I checked, the results weren't available. But if anybody knows any different and they're out now or somebody's seen the results, please pop them in the chat if you're able to share them with us. Otherwise, we are waiting with bated breath to see what the current situation is. But at the time of the last purely UK survey that we had, the prevalence of healthcare infection was at 6.4% in England, and that had reduced from 8.2% in 2006. And the prevalence of antimicrobial use was 34.7%. So a third of the people in hospital at that point in time were on antimicrobials. And almost half of those in the point prevalence survey had at least one invasive device in situ. So we know from that they would have been an increased risk of infection by the nature of them having an invasive device there. And the chart on the right-hand side there shows you the proportion of the infections based on the types of infections. So pneumonia was the largest proportion of healthcare-associated infection, and closely followed there by urinary tract infection. And you can see that the others were their surgical site infection, and then coming round to the unknown. So pneumonia and urinary tract infections, clearly what we had to put some focus on in England at that point in time. Now, more recent data is from the European point prevalence survey that took place in 2016 and 17. And the UK participated in this, all of the countries for the acute hospitals, but England didn't participate in the community part of this, which I'll show you on the next slide. So this is really useful information to give us again on how we were doing. So you have to be a little bit cautious about the interpretation with England on 6.4% and Scotland on 4.3%, with the difference in the number of beds, etc. But clearly for the England comparison, it was about the same as what we could see previously. And for the types of infections, pneumonia was still the greatest burden of infection there, followed by surgical site infection and urinary tract infection, and not very different at 16 and 15% there. But you can see the top organisms that were causing the problem. Right across the board, it was E. coli. For 3 countries, it was Staph aureus, whereas C. diff was an issue in Wales more than it was in some of the other countries. So it's the second highest organism there. And you can see there, Staph aureus, C. difficile, Enterococcus species, and Klebsiella were the ones that were causing the problems at that point in time. For the long-term care facilities, as I mentioned, England didn't participate in these, but for the prevalence of infection, Northern Ireland, Scotland and Wales, it ranged from 3.7% to 6% there. You can see the organisms that were causing the problem slightly different. Staph aureus was more of a problem in the long-term care facilities than it was in the acute facilities, probably down to being more skin infections and perhaps more long-term wound problems in those settings. E. coli being the next problem causative organism in all of the areas. And you can see from the bar chart at the bottom there that urinary tract infections were probably the greatest burden in Northern Ireland and Wales. Scotland, perhaps it would have been respiratory tract infections there. But you can see we're still talking about those two as being the main burden of infection there. And like I said, it would be really, really interesting when we get the latest data for us to be able to see what the comparisons are and what impact we've made and what impact some of the gram-negative organisms that we're now seeing problems with are causing in our healthcare facilities. Now, looking at it more globally, after the UK, we're thinking more globally. There are new and complex threats to health globally, and because of that, the United Nations member states put together an agenda for sustainable development. And the Sustainable Development Goals are an ambition that reduce the impact of poverty, climate change, population growth, premature death, and resistance of infections to traditional treatments. Sustainable Development Goal 3 is the one that particularly links into the infection prevention and control arena. Good health and well-being is essential to being sustainable, and the health of the planet is also really important for us in terms of infection prevention and control. Now, you have more on this later in the programme about planetary health and about sustainability. So I'm not going to go into significant detail about that at the moment, just to make that link between where we are. And from planetary health, it is more important that we're aware of what's happening globally and what is happening in terms of climate change, because it impacts on the types of infections that we're going to see. The map on the right that you can see there is not where we have West Nile virus, but where we have the type of mosquitoes that carry the West Nile virus. And certainly here in Spain, there has been significant concern about it this year. I think we've had 4 deaths from West Nile virus, and they have quite a programme for prevention of mosquitoes in the towns and the cities. Little bit harder in the campo, the country areas, but in most towns and cities, they have programs to reduce mosquitoes, to reduce the risk of these mosquito-borne diseases, and the ones that traditionally we wouldn't have seen, like the West Nile virus. The Lancet has information as well on climate change and infectious disease in Europe, and that's a really good article. It's in the reference list, that shows you the impact, the projection, and where we think we might be going, especially with things like vector-borne diseases that we need to be more aware of, the ticks and that kind of thing. The CDC one there is an advisory that they issued about severe infections with Vibrio bonificus. I'm no good at pronouncing these things, but I think that's how you pronounce it. Infections in the US states associated with warming of coastal waters. So you only see this in warmer waters, and they wouldn't have seen this bacteria previously, but now they are. And it can cause death in people that get infected with it. So it's something that they're concerned enough about to put out an advisory. And then you have the CDC pages there about the risk of infectious diseases because of climate change. Now, the article at the bottom there, which again is in your reference list, is the first one that makes an association between particulate matter, so the contamination that we have in our cities, the air pollution, and clinical antibiotic resistance. And what they found from this was that there was a link between them, an association between them, but what they didn't do with the research is look to see whether that was the causative reason. They're just making the link between it rather than saying that pollution is directly leading to clinical antimicrobial resistance. But we also know that in the UK there are cases of people getting severe respiratory disease due to the pollution, etc., which makes them more susceptible to chest infections, etc. So they're all very, very much linked together. So you do have a video that Rose Gallagher from the RCN, the lead for IPC and for sustainability, has recorded for us to give you more of an overview of planetary health and the link to infection prevention and control. Now, what is driving policy in the UK? And policy and politics are inextricably linked together and are both very, very much important, because it's the politicians that will drive some of the policies that help us or hinder us with infection prevention and control. Some of the policies that governments put in will not be necessarily around health. The ones for IPC are mainly related to health, but other ones can impact on us as well, such as the environmental ones and the education ones as well. So policies are not laws in themselves, but they're the ones that can lead to laws to effect the change. And we did see throughout my career the impact and perception of infection that was significant to drive policy from 2000 to 2007. Prior to that, the focus on infection prevention and control was not political at all. It was all about those of us like me and Dinah and Betty Bowell that she described that were the driving factors behind it at that point in time. And it wasn't necessarily seen as being a political imperative. But then we had MRSA and we had Clostridium difficile, and all of a sudden people were sitting up and taking notice of this. And we had a lot about dirty hospitals at that point in time. And the predecessor to the Care Quality Commission, who do the regulation and inspection in the UK, the Healthcare Commission, went in and inspected, and they published a list of trusts that were named as unhygienic. And also at that point in time, there were some significant investigations into outbreaks of Clostridium difficile in Stoke Mandeville Hospital and in Maidstone and Tunbridge Wells. And I was fortunate to be the infection prevention and control nurse specialist that did those investigations. And I actually took that picture there. That was a sink in a clinical room on a ward. And I don't think that any of us now would expect to walk into a hospital and see something like that. Now, yes, that's an extreme picture, but it wasn't unusual at that point in time that people didn't take it as seriously as they should have done. But things have changed. And also antimicrobial resistance strategies and policy have come into place since that part of time. So what do we have as IPC policy examples in this current point in time? Well, we've got the National IPC Manual for England. Scotland's had their manual for a lot longer. Wales piggybacks not often off the back of the English ones, and will refer to those manuals. A lot of their technical stuff around the environment as well are English documents that they have adapted for Wales. Scotland's tend to be slightly different documents, and Northern Ireland's will be. And with the link up now between Northern Ireland and Ireland, we're starting to see a lot of joint policies there, more than we ever did before. We've got the Infection Prevention and Control Education Framework, which is a good tool for people to be able to look at and use and look at the levels of education. You do need to critically appraise these things just as much as you need to critically appraise research. And obviously Dinah does a section on that for us, because they may not be as applicable in your settings as you think they could be. We've got an infectious disease strategy that runs from 2020 to 2025. We've got the UK 5-year action plan for antimicrobial resistance, which sets the policy for what the country is going to aim to do. I'll tell you a little bit more about that. We have drivers that the NHS can use to improve infection prevention and control. Now, one of the examples of that in the NHS is the standard contract for minimising C. difficile and gram-negative organisms. And prior to you joining us, me and Dinah were talking about some of the differences in the different countries. And Dinah was reflecting on some work that she'd done in Wales, where they were struggling with C. difficile. And one of the reasons why they were struggling more than England was because they didn't have the driver of the contract, which set the targets and set the fines. So unfortunately, money sometimes is one of the drivers for policy and healthcare. And in primary care, you've got the QOF points for immunisations, quality output framework, which GPs will be rewarded for doing things like immunisation. And clearly immunisation has a link to infection prevention control. Dinah mentioned some of these as she was going through her lecture, she mentioned the vaccination now that we have against chickenpox, which is very helpful to those of us that are infection prevention and control practitioners and cover children's hospitals or cover specialist units when people are immunocompromised. So to have a population that we know are immunised as we go into the future will be really, really helpful for those situations. Just a reminder, I've mentioned where I can that healthcare is devolved from the central government to the 4 countries of the UK. So each devolved system has the power to set their own policy. On the whole, you'll see with infection prevention and control that we do similar policies because we base them on principles, and they are evidence-based policies the majority of the time. Other policies around health and education and environment might not be quite the same, as you will see England, Wales, Northern Ireland, Scotland differing. So one of the key drivers in the law was the provision of a code of practice to reduce risk of healthcare associated infection that was initially implemented just for NHS bodies in England. And England led the way with this. I will show you the comparison ones for the other countries, but it was England that first put this in place. So the law was the Healthcare Act. The policy was the code of practice. And this set the standards that have to be met. Originally, as I said, for NHS bodies, that's now widened to any healthcare provider and social care as well. And it really sets a framework for accountability for how you deliver and manage infection prevention services within an organisation that delivers health and social care services. There is a requirement to keep the code under review, and it was updated in 2022. At the moment, it has 10 standards described in the English one, and we will do more about this on your last session when we look at accountability and management of IPC. As I mentioned, there are different codes for different countries: Wales, Scotland, Northern Ireland. If you want to have a look at these, you have the references there for you to be able to go to. But as I said, more on the codes of practice and standards later in the programme, and we do more on regulation later in the programme. But just briefly, it's important that we mention the people that do the regulation. So I've said in England, the Care Quality Commission; Wales, Healthcare Inspectorate Wales; Scotland, Health Improvement Scotland; Northern Ireland, Regulation and Quality Improvement Authority. So all the countries have organisations that are responsible for monitoring against the standards that are set to improve infection prevention and control in health and social care organisations. Moving on now to think about the link between public health and infection prevention and control. I've demonstrated it here with the Venn diagram there, which shows the overlap between them all. The 3 in the English system that overlap when it comes to our roles. I know we've got somebody here from the UK HSA, which is brilliant. We've got infection prevention and control there. And in England, we've got this Office for Health Improvement and Disparities. And on the next slide, the 2 slides down, I'll show you how the UK Health Security Agency and the Office for Health Improvement and Disparities links in to those of us that work and breathe infection prevention and control on a daily basis. So the definition of public health here is it supports individuals, organisations and society to tackle preventable disease, mortality and disability. And the way that's done through prevention, reducing the incidence of ill health and supporting healthier lifestyles; through protection, the surveillance and monitoring of infectious disease, emergency response and immunisation; and through promotion, health education and commissioning services to meet specific health needs. So you can put IPC into the prevention, reducing the incidence of ill health. People who have diabetes are more at risk of infection. The protection, the surveillance and monitoring, and the promotion with the health education and commissioning services. So our colleagues at the UK Health Security Agency have this strategic plan, 2003 to 2026, as to how they are going to work. They're going to be prepared, they're going to respond, and they're going to build the UK's health security capacity. So the two red boxes there are their strategic priorities that absolutely link directly across to what we're doing on this course. Proven health outcomes through vaccines, because we are talking about vaccine preventable diseases on this, and reducing the impact of infectious diseases and antimicrobial resistance. And the two are linked together very clearly through the UK HSA strategic priorities there. The Office for Health Improvement and Disparities focus on the nation's health. Expects everyone to live more of life in good health and levelling up the health disparities that we see across the country and breaking the link between background and prospects for a healthier life. And I've just picked up some of the areas from their website where it links across to IPC. So you've got the communicable disease page here, which you can link through and tells you about testing and preventing communicable disease there. There are country-specific pages which are useful when you're looking at the type of infections that migrants may be able to bring in. The COVID-19 Migrant Health Guide, a particular one there, Chagas Disease Migrant Health Guide. So from an IPC point of view, things that we might not need to be aware of on hospital, our colleagues that work in the community that have direct contact with migrants or commissioning services that support migrants need to be aware of these things through the Office for Health Improvement and Disparities. So all three inextricably linked: IPC, UK Health Security Agency, and the Office for Health Improvement and Disparities in England. The other countries have similar approaches to make sure that the three areas are covered. So let's move on now to think about antimicrobial resistance. And what we're talking about here are those infections with resistant organisms, and they could be bacteria, they could be viruses, they could be fungi. But we know that if you have an infection with a resistant organism, you have increased morbidity and mortality. They extend somebody's stay in hospital. We may have reduced or no treatment options available for them, and it could lead in the future to potentially untreatable infections. Now, going back to a pre-antibiotic era would be absolutely disastrous for healthcare. It may mean that we would have to stop some of the treatments that we're able to do, for example, some of the chemotherapy. It would impact on things that we do every day, such as hip replacements and knee replacements, anything that requires antibiotic coverage for it, or we would need to be able to reduce somebody's risk of them getting an infection, like when we're doing the chemotherapy, may not be able to do those. And it increases healthcare costs because the antimicrobials that we would use for the resistant organisms are usually significantly more expensive than the normal ones we've had, plus the extended stays in hospital increase the healthcare costs as well. So linking the prevention of infection to antimicrobial resistance, the more infection we have, that drives the demands for antibiotics. So the more we can reduce infections, the more we can reduce the demand for antibiotics. If somebody is on antibiotics, that selective pressure can enable the resistant bacteria to grow and thrive. So they may not have been causing a problem until somebody was given antibiotics for a non-linked infection, and now they are. And we know that resistance or resistant bacteria can spread between people and between body sites. And Dinah will talk a little bit more about the transmission of antimicrobial resistance in one of her lectures later. So what is antimicrobial resistance? As I mentioned, it can be in bacteria, it can be in fungi, viruses, and protozoa. It is a major threat in and to the UK. It's not confined to one outbreak. Outbreaks often involve mobile DNA that spreads between different species of bacteria using plasmids. Again, Dinah will talk a little bit more about this. And as I've already mentioned, we've got the blurring now between traditional hospital and community boundaries, and we have people that are moving between services on a regular basis, between community, between social care, between community hospitals, between acute hospitals. So there's plenty of opportunity for antimicrobial resistance to spread very, very nicely. So let's have a little bit about the European prevalence study that I've mentioned earlier. 33% of the patients in that were receiving one or more antimicrobials, so about a third again, and 92.3 of those were antibacterial. So for people in hospitals and in community care settings, it's mainly antibiotics that people are receiving. The reason for use was documented in 80.2% of the cases. Now, I think that's actually not bad. When I think back to the days when we had to deal with C. diff that had become endemic in one of my hospitals in Bristol, when we started doing some auditing of the reason for use being documented, it was down in around about the 30%. So that's reassuring to see that people are now aware that they have to write that reason down. So their reasoning for why they're using it is clearly documented. 41% were on broad spectrum antibiotics. So the risk with broad spectrum antibiotics is higher for allowing the selective pressure to happen. But you can see on the European prevalence map there that although the overall rate of people being on antibiotics was 32.3%, there is a vast difference between the countries. A lot of you know that I reside most of my life in Spain. So you can see Spain's not one of the great countries down here when it comes to the number of patients on antimicrobials there. Greece, not great. Italy and some of the Eastern European countries as well there, not great. Whereas the more developed, some of the more northern developed countries, slightly lower rates. I think these are areas where they focused on it more. I was very fortunate that I spent a month in Denmark looking at how they do infection prevention and control. And we also had somebody on there that had come from Holland. And they were describing how their facilities were mainly in single rooms. And they had a massive focus at that point in time on MRSA, and anybody with MRSA would have been isolated in a single room. So I think that's why at that point in time, those countries were using a lot less antibiotics than some of the other countries. This is the SBauer report for 2022 to 23. And within this, it shows the burden of antibiotic resistant bloodstream episodes. And you can see this is from 2018 up to 2022 there. So the bulk of antibiotic resistant bloodstream infections in all those years was E. coli. So the gram negatives becoming quite important there for us to focus our activity on. Staph aureus less so, but has been a problem in the past. But E. coli there is our biggest thing that we need to look at. So we know from our policy point of view that that's one of the areas, and from our local point of view, that's one of the areas that we really need to be focusing our IPC prevention and our research on. So what is the UK committed to do around antimicrobial resistance? What it said is it wants by 2040 a world in which antimicrobial resistance is effectively contained and controlled. We're 16 years away from that. That was a 20-year vision then in 2019. So we still got a long way to go. There's still a lot more to do. And what they're looking at, we should have as a lower burden of infection, treatment of resistant infection and minimized transmission, optimal use of antimicrobials and good antimicrobial stewardship across all sectors, and new diagnostics, therapies, vaccines and interventions. So speeding up the way we can diagnose infections, speeding up how quickly we can test for any genes that will encode resistance there. So in May 2004, the UK published their second National Action Plan, on antimicrobial resistance, and there are 4 key areas here: reducing the need for and unintentional exposure to antimicrobials, optimizing the use of antimicrobials, innovation and influence, antimicrobial resistance diplomacy. So the 2 at the bottom, the innovation and influence, and then AMR diplomacy, are about the wider aspects of policy that will influence antimicrobial resistance. The 2 at the top there, the reducing the need for and unintentional exposure to antibiotics. This is where infection prevention sits in. It's there. Improved interventions, the built environment, and reducing waste minimisation and effective waste management. And what they're talking about there is the spread of antibiotics through things like the water system. Strengthen surveillance and making sure the public are aware. Optimising the use of antimicrobials, so having good antimicrobial stewardship in place. And having a workforce to support antimicrobial resistance. So the training that we give you, having the systems to support animal health to reduce the need for use of antimicrobials. So there's a lot to be done, but the UK is focused on this and focused on very much on that link between infection prevention and control and antimicrobial resistance. So NICE, they have some guidance on antimicrobial stewardship, and their definition for this is an organisational or healthcare system-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. And their recommendations sit in these 9 areas here: having a programme, having a team, having the right interventions, good communication, how laboratory testing support it, having good antimicrobial guidelines, and having the right prescribing in place. So if you would like to look further into antimicrobial stewardship, the NICE guidelines are somewhere for you to look. And linking it through to nursing competencies, this is a great article. Again, I put the link there for you to be able to go and have a look at this one. And this is a model of the nursing role in antimicrobial stewardship. So this is from the research study. They pulled out these 6 domains that are really important for nurses to be aware about of their roles and how they support antimicrobial stewardship through their nursing role. So IPC there is very clear at domain 1, going down to nurses themselves, even at domain 4, being prescribers themselves and having good antimicrobial prescribing practice. There is more on antimicrobial resistance on the learning management system. So please do use that resource as and when you can. So to finish off, I can't do this section without talking about COVID. Now, this is my personal opinion about why I think COVID taught us these lessons while we were dealing with it. The first one for me was the importance of being prepared. I think COVID caught us all out. I know Dinah can't talk very much about things at the moment, but the COVID inquiry is happening as we speak, and I know how well prepared we were for it will be looked at as part of that. The thing for me is during COVID, I worked both for a clinical commissioning group and I worked for a community provider. What I learned from being part of that was how important it was that we all work together as a system. And I think that's this is one of the positive things that I think has come out of it, is we've realised that we've all got to work together with this. And I think that's why now we're seeing on this course that we've got people from all different parts of the system coming on it, so that we're all understanding the same, using the same types of language and knowing what each other is doing, which is great. It definitely taught us that the prevention of infection has got to consider more than traditional clinical work. There had to be office spaces. We had to think about public transport. I know some of my colleagues were even involved with advising into like the film and television industry about how they could reduce transmission there so that they could all get back to work. So it's not just about hospitals and healthcare now. It's about how we think about infections, how they spread outside of traditional clinical work. And I think it taught us now more than ever is the time to invest in our infection prevention and control services, and also how we invest in the environment. So we've got a better environment that supports the prevention of spread of infections, whether they be airborne, whether they be droplet spread, whether they be the route of contact spread as well. I'm sure most of us have worked in very old hospitals where it's been very, very difficult to prevent infection. And then we move into nice new hospitals, and it makes it a lot easier if you have a lot more single rooms and if you have your facilities better. So for me, that's what COVID taught us. I got to work with people that I traditionally wouldn't have worked with as an infection prevention and control nurse, and that would have been care and nursing home managers who really stepped up to the mark for me during COVID and got very, very good at doing risk assessments themselves. So the importance for me, again, of risk assessment and being able to adapt it to the environment you work in were really, really good lessons for us. So to summarise where I think we are at the moment with the current context of IPC, it still is a patient safety and quality issue wherever health and care are delivered. Urinary tract and respiratory infections at the moment continue to be the highest burden of healthcare associated infection. You can't take out that link now between planetary health and IP&C, and that's going to become more important as the climate changes across the world. The national policy drivers influence the focus on and actions for IPC, and then we have the regulation of health and care in the UK through the application of standards and an accountability framework. Public health and IPC are complementary areas, and we all play our role to reduce HCAI and reduce antimicrobial resistance, which is inextricably linked. And what I've just mentioned about COVID, the importance of IPC, the focus of out-of-hospital IC, as well as environmental IPC. So there you have a reference list of all the things I've mentioned there. And there's some additional reading that you may wish to go and have a look at some point during the course or at the end of the course. So I'm going to stop sharing at this point and ask if anybody has any questions on what you've heard there. Stunned you all into silence. Does anybody know when we're getting the results of the prevalence survey? No. It's hugely frustrating. I remember when we did the second UK prevalence survey, and I was involved in sort of the oversight group for it. And it's so frustrating that it takes so long from getting the data in to getting the reports out. But I absolutely understand why it takes so long, because the analysis takes a long time. Then the writing up of it takes a long time. Then if it's UK-wide, you've got to get agreement from all the 4 sort of governments that you can release it. So I'm not criticising this for us, but boy, do we need that now. We need to know a little bit more about what's going on. Anybody want to add anything about what you see with the policy drivers or anything in your areas or the working together? You're all gone deathly quiet again, haven't you? We're stunning you into silence this morning. No? Okay. So we'll stop and take another break at this stage. It's just coming up to 25 past. So we're scheduled to have it's 10 minutes. Well, we've got plenty of time, so actually we can have a 15-minute break. So if we come back, please, 25 past, again at 22. That'd be lovely. Thank you. Back to you then, Dinah.
Lovely. This one? Yeah, thanks. Right, we're just getting the screen ready.
Yeah, if people want to pop their cameras off, that'd be great. Yeah, we got the screen, so it's fantastic.
You can get rid of that.
It'll go down in a second.
Yeah. There you go. Lovely. Okay, now in this second session that I'm giving, I'm going to talk about bacteria. And then tomorrow we'll talk about viruses and the other groups of organisms. But what I should have said before we started is that today we're going to work very hard indeed. And today you will be tired by lunchtime, by the time we've finished. Tomorrow won't be so bad though. Tomorrow will be much better. But when we meet again, when I meet you again in a few weeks' time, that day we shall work extremely hard. But today is much harder than tomorrow. So let's talk about the natural history of bacteria. Bacteria are the oldest living organisms that we know of, and they appeared 4 billion years ago. They're ubiquitous, which means that they're found everywhere, and most bacteria are harmless saprophytes. They live on dead organic matter, and they play a vital role breaking down complex organic molecules to simple ones. And the world would come to a stop if they didn't, because along with fungi that we should talk about tomorrow, if they didn't do their work on things that have died, the world would just be cluttered up with dead things that didn't break down and disintegrate at all. Some bacteria are of commercial importance. Now, bacteria have the same characteristics as all other living organisms. They have a cellular structure, they respire and they generate, they grow and they adapt to their surroundings, they metabolize, which means that they consume food and convert it into energy, and they maintain homeostasis, which means that they keep a stable internal environment despite the outside environment changing. The outside environment may be hot or dry, it may be, the pH of it may change, all sorts of things may go on in the environment, but the bacteria have to adapt to that in order to function. So they respond to environmental change, they move about, and they reproduce, and they pass their genetic genetic material to their offspring. So bacteria as pathogens, the ones that cause disease, are certainly not all bacteria in the group by any means. About 50 species of bacteria are pathogenic, and they cause human disease, animal disease, and a few cause plant diseases as well. Their virulence, their ability to cause disease, is highly variable. Yersinia pestis is the organism that causes plague. And at the other end of the spectrum, there are bacteria that we call opportunists because they cause infections in people who are generally not very well, or they manage to get into a part of the body that is usually free of microorganisms. Now, you can't have a touch of the plague. If you've got plague, you are very, very ill. You can't have a bit of the plague. Whereas Klebsiella is an example of an organism that generally will cause an infection if it gets in your bladder, which is usually sterile, or if you are very unwell. The normal commensal flora is the flora that lives harmlessly in or on one part of your body, but it can cause a damage if it gets to another part. So the definition of a commensal organism of any kind is one that gets a benefit from its host. And so the characteristics of commensal bacteria are that they receive food and shelter from the host, and in return, they protect the host from invading pathogens. So where you're sitting, you're covered in bacteria, and your gut is full of them. And if you're female and you've got a vagina, then it's full of bacteria. And the benefit of them is that it keeps invading bacteria out. It's when you take antibiotics and you destroy your ordinary gut bacteria that you get an overgrowth and you get an upset stomach, because foreign ones are able to grow instead. So this is a reciprocal arrangement. The host and the bacteria benefit from one another. There's shelter and nutrition for the bacteria, and the human being is protected from potential pathogens. And so we're just fiddling about with the screen. Thank you. And commensal bacteria can generate infection if they get transferred to a different anatomical site. So something on your skin, if it gets transferred deeper into your body, might be a commensal on your skin, but it can cause infection if it gets into another place. So here's an example here are examples of infection caused by the normal flora of the body. E. coli, Escherichia coli, normally lives in your bowel, but if it gets into your bladder, it will cause a urinary tract infection. And women are very prone to urinary tract infections because of the short length of the urethra. Staphylococcus aureus lives on the skin of about 30% of ordinary people in the population, probably a higher percentage if they work in healthcare. But if it gets into a surgical wound, it can cause surgical site infection. But when it's living on your skin, it does you no harm, and you don't even know you've got it. The old-fashioned name Clostridium difficile, I can only say Clostridioides on a good day if I say it very fast. It normally lives inside your gut, and just a few bacteria live there. But if you receive broad-spectrum antibiotics, then the rest of your gut flora tends to succumb to that, and you get an overgrowth with C. diff and an infection that way. Enterococcus faecalis lives in your gut, as you can tell from its name, but if it gets into the urinary tract or a wound or into the bloodstream, it can cause severe infections. Streptococcus pneumoniae is usually carried in the respiratory tract in about 5 to 90% of the population. It causes pneumonia, otitis media, infection of the middle ear, or it can cause severe invasive infections, bloodstream infections, and meningitis if it gets into the wrong part of your body. Bacteroides fragilis lives in the lower intestine. It usually stays there, but if it gets anywhere else, it can cause severe abscesses and peritonitis. Staph epidermidis lives on your skin. And here it lives on everybody. Where you're sitting, you're covered in it. You don't know you've got it. It's a commensal, but it particularly likes living on plastic surfaces. And so it can cover the surface of an indwelling device and cause infections on things like venous cannulae, on shunts, on other medical devices like that. And we'll talk more about staph epidermidis later on. Another group of words that you have to get your head around is endogenous and exogenous infection. Endogenous infection is self-infection. It occurs when pathogens from one anatomical site get transferred to another on the same person. Exogenous infection is a fancy word for cross-infection. It's the transfer of infection between different people. So it's important for us to prevent both. So examples of the normal flora of your body, Staph epidermidis goes on everybody, and Staph aureus goes on 30% of the population. And in the upper respiratory tract, Streptococcus viridans normally lives there. In the large intestine, Bacteroides, E. coli, Proteus, and Clostridia. And Enterococcus, as we said, normally live in your large intestine. And in the vagina, Lactobacilli. I know you get Lactobacilli in yogurt, in what they call live yogurt. It's not the same species of Lactobacilli. And on your skin, Staph epidermidis lives. We have to get our heads around infection and colonization. Infection occurs when a pathogen gains access to the host tissues and there's a host response. So infection occurs when the neutrophils, the white blood cells, are present. If you look at a laboratory report, if somebody's urine has been sent in, they often report pus cells. Pus cells is another way of describing white blood cells. If somebody's got a genuine urinary tract infection, there will be white blood cells in it. And if a wound is infected, then there will be pus in the wound. And if somebody has an infection, they very often run a temperature. Colonization occurs when the pathogen is present, but there is no host response and no signs or symptoms of infection. So indicators of infection are large numbers of the same sort of bacteria and somebody suffering from pain usually. And if they've got an infected wound, it's sore. If you've got a urinary tract infection, then you will suffer dysuria. And people with an infection very often run pyrexias, although very older people sometimes don't. An indicator of colonization is scant growth. If you send a specimen of urine to the laboratory and there's a genuine infection there, then the person working in the laboratory who's examined it will usually find that there's large numbers of bacteria of the same kind there. If it's an E. coli infection, there will be lots of E. coli. If it's a Klebsiella infection, obviously there'll be a lot of Klebsiella. There will be pus in the urine. There will be lots of pus cells. They'll often write pus cells plus there. The urine will often smell. The patient will generally tell you they don't feel very well. They may be having pyrexia. But if there's colonization there, then there's a scant growth of bacteria, often lots of different sorts of bacteria there. And the person working in the laboratory will write that there's a mixed bacterial growth. And they will, they may say a few cells of Klebsiella, a few cells of E. coli, but not large numbers of the same bacterium. But colonization is clinically significant. Otherwise, I wouldn't be sitting here talking about it, because a colonized site is, of course, a reservoir for infection. It has the potential to cause cross-infection to another person. If you deal with somebody who's colonized and you don't clean your hands when you move on to the next patient, or if they have contact with a fomite, and a surface able to transfer disease, then that more susceptible person may get infected, even though the original person doesn't have the signs and symptoms of infection. And colonization usually comes before infection. When an outbreak occurs, then a patient or more than one patient on the ward or in the clinical area may be carrying the bacteria. They may not have any signs and symptoms of infection, but then they may develop them and there's an outbreak. Endogenous infection occurs from one site on the body that's of the same person. For example, if you've got an infection, if you've got Staph aureus in your nose and you touch a wound on the same patient without cleaning your hands in between, then that patient will get an endogenous infection, a self-infection from one part of their body to another. Cross-infection occurs when you move from one patient to another and transfer infection that way. And when somebody is colonized, it's important to obtain specimens for laboratory diagnosis, because the patient may need to be treated even if they're only just carrying the bacteria. And it's important to give the appropriate antimicrobial. So fundamental infection prevention measures are very important always, and we must never forget them. The importance of hand hygiene, changing gloves between patients, always cleaning hands even when gloves have been worn, because they may become contaminated when you remove the gloves, and cleaning hands between moving sites between the patient. And it's just not very nice to fiddle about with somebody's nether end and then to fiddle about with their mouth. It's what you would call aesthetically not desirable, but you could be transferring infection as well. Disinfecting equipment is very important. Using disposables is very important. I know we're all into sustainability these days, but disposables do have their uses. Now, we classify bacteria according to their shape. Cocci are round bacteria. Staph aureus forms a cluster of bacteria. Neisseria gonorrhea is a diplococcus, two little round cells together, where Streptococcus pneumoniae, which is responsible for sore throats, or sometimes more serious infections, including chest infections, is usually present as a chain. Bacilli are rod-shaped bacteria. E. coli is a bacillus, it's rod-shaped. And so Pseudomonas is like that, and Klebsiella, also Proteus, an organism called Serratia that you might or might not have heard of, and Salmonella, the food poisoning organism. They're all bacilli. Serratia is a bacterium that often causes outbreaks of infection on neonatal units. It can cause severe infection. Sometimes they make the news. Vibrio are curved bacteria. Vibrio cholerae causes cholera. Campylobacter, that causes food poisoning, is also a Vibrio. Spirochetes are very tiny little things, and I'll show you a picture of one in a minute. The picture I've got is not particularly pretty, but sometimes some microscope pictures of them make them look very attractive. Treponema pallidum is an example of a spirochete, and Treponema pallidum causes syphilis. Leptospira, that causes Weil's disease, spread by rats, is also a spirochete. So is Borrelia, which causes Lyme disease. This is a picture of the different sorts of bacteria. And at the top, you've got a chain of bacteria, and those pink things, and those are cocci. They're round. Below it, you've got a picture of bacilli that are rod-shaped, single ones that are bright blue. Up in the right-hand corner, if you look carefully and use a bit of imagination, you can see that those are curved, those are vibrios, and underneath that orangey thing, those things that look like old-fashioned telephone cables, those are spirochetes. Spirochetes are tiny, so the amount of magnification on these pictures is not the same. And spirochetes are much, much smaller than the other ones. The other thing that I should say to you also is that in life, of course, when you look at bacteria, they're not these virulently brilliant colours either. The colours are given to them by the microscope stains that we add to help us see the cells. In life, they wouldn't be those really bright colours. Now, bacterial structure, bacteria are unicellular. They consist of one cell, and that one cell is a viable organism. So if we look back at this slide, one of those round pink things performs all the activities of living organisms that I told you about before. Immediately below it, one of those blue bacilli breathes and reproduces and does all the things of living organisms. So bacterial morphology. Now what have I done now? Bacterial morphology. Let's get on to bacterial structure. So bacteria are single-celled. One single cell is a viable organism. It does everything in order to survive and reproduce. And there is no division of labor between the cells with bacteria. One cell performs all those functions of living. That's not true of the human body or of an animal body, of course, or even of a plant. We have different organs that do different things. You have liver cells that metabolize, you have muscle cells that move, you have glandular cells that secrete, and nerve cells that produce nervous impulses, and all the different things that different organs do. But and you have parts, parts of your body breathe, other parts of it are specialized to reproduce. But one bacterial cell does the lot. And if we want to look at the fine detail of bacterial cells, then we use the electron microscope, which multiplies to a very, very high magnification. And that enables us to look at the cellular ultrastructure of the bacteria, their fine details. And as we've said, all living cells must be fixed, killed, before we can examine them. So the bacterial ultrastructure that is common to all bacteria, an important thing to remember is that bacterial cells are very different to the cells of higher organisms. Higher organisms are described as eukaryotic because they have a nuclear membrane and they have defined organelles inside them, all bound by membranes. Bacterial cells are much simpler, and we describe them as prokaryotic. They have no nucleus. The nucleus of a higher organism contains the chromosomes, which are the things that define what we are. But the genetic material of bacterial cells, the DNA, lies directly in the cell cytoplasm. And the other organelles that make up a bacterial cell lie in the cytoplasm as well. The ribosomes make protein. Bacterial cell walls have rigid cell walls that give structure and support to the bacterial cell wall and protects the cellular components, whereas animals and plants have rigid cell walls, and animals and human beings do not. And this is very important clinically, otherwise I wouldn't be telling you about it, because antibiotics are effective against bacteria, but they don't harm higher organisms. I know they can have side effects, but if you take an antibiotic, it will kill the bacteria, but it won't kill the rest of the cells in your body, which is why antibiotics are often described as magic bullets, or they used to be described as magic bullets, because they have a very specific action. Now, this is not a very good slide. You can find all sorts of things on the internet, and it's very interesting what you can't find. And I couldn't find very good slides of these, but the bacterial cell wall that you see on the left, you can see it has a thick outer capsule, and you can see that red thing that is lying directly in the cytoplasm is just there, and it's not bound by a membrane. The animal cell to the right of it has no thick outer structure all around it. It doesn't have a thick outer coat, and the nucleus looks to me like it ought to be that purple thing in the middle. It has a distinct nucleus that contains its genetic material, and it has other organelles in the cytoplasm that are bound by membranes. So bacteria and antibiotics. Antibiotics are the magic bullets because the cells of bacteria and eukaryotic organisms are so different. Different antibiotics act in different ways. Some of them prevent the synthesis of the bacterial cell wall. Cephalosporins, vancomycin, and carbapenem are examples of antibiotics that behave in that way. Some antibiotics prevent the synthesis of bacterial proteins. Gentamicin is like that, and so is erythromycin. If you work in an acute area, you probably will give people gentamicin quite often. If you work in the community, you will give erythromycin quite often, but you don't give erythromycin so often in hospitals. Some antibiotics prevent the formation of bacterial DNA. Trimethoprim, which is the first line of treatment for urinary tract infections, is an example of that. Cotrimoxazole is also an example of something that prevents bacterial DNA forming. So there are variations also in bacterial morphology. Bacteria, as well as their shape, have different sorts of organelles. Some bacteria are very highly motile because they have a flagellum. You could see that on the slide I showed you before. Flagellum is a whip-like structure, and the bacteria that have them move about a lot. Salmonella, the food poisoning organism, moves about a lot. So does the organism Proteus. Pili, which I mentioned before in relation to Neisseria gonorrhea, are tiny little hairs, and they allow the bacterium to attach to the host cell. Neisseria attaches itself to the cervix in women and to mainly to the urethral mucosa in men. And without the pili, the bacterium can't be pathogenic because it can't hold on. Some bacteria have a mucus capsule, and that avoids the cell underneath from drying out. Some strains of Klebsiella are like that. A lot of the original research to do with cross-infection in hospital was done in St. Thomas's Hospital in their intensive care unit in the 1970s. And they had outbreaks of infection caused by Klebsiella, and the Klebsiella that were causing infections were almost inevitably the ones with a thick mucus capsule because they could survive in the environment longer without drying out. So they could survive on people's hands, and if they weren't washed off properly, then they would survive when you went to the next person. So morphology, you can see, influences virulence. The Neisseria gonorrhoeae that doesn't have the pili isn't pathogenic. And the Klebsiella that doesn't have the mucus capsule is less pathogenic. Another distinction that we need to make is between gram-positive and gram-negative bacteria. And this relates to the way that bacteria are stained in the laboratory, but it also has a relationship to the way that the bacteria behave. Gram staining is the first step that we use to identify bacteria in a laboratory specimen. And the reaction to Gram's dye is determined by the chemical composition of the bacterial cell wall. And that reaction gives us a very good indication of the structure of the bacteria and how they're going to function. Gram-positive bacteria are generally quite resistant to desiccation. They don't dry out, they resist drying out. They tolerate dry conditions better than gram-negative bacteria generally, but they're never flagellated, they're never mobile, and some species, but not all of them, form spores. Staph aureus is gram-positive bacterium, but it never forms spores. Gram-negative bacteria thrive in damp conditions, and they have very simple growth requirements. They only need a few little bits of nutrient, and they can multiply in large numbers. They're often flagellated. They're not all flagellated, but many of them are. They're motile. They never form spores, and they're often naturally, intrinsically resistant to a lot of antibiotics. People often think bacteria, oh yes, under adverse conditions, they all form spores, and the spores are very dangerous. But not all of them form spores at all. That is an oversimplification. Mycobacteria, the bacteria that cause tuberculosis, TB, don't respond very well to gram stain because they have a very thick, waxy cell wall, and they're often described as acid-fast. If you see AFB written on a laboratory specimen, then they're referring to mycobacteria. I think it's quite an old-fashioned way of naming them, but it's important because if you work in an area, particularly in an inner city area where you're likely to have many patients with TB, you're very likely to see a laboratory form that says AFBs. It's very important also to remember to stop and look at laboratory forms properly. Sometimes when they describe things from the laboratory, they say things like loose brown stool received, no salmonella, no Shigella, which are the food poisoning organisms. So they'll describe what they see and they'll tell you what isn't present. I remember this very advisedly because when I was young and poor, I used to go and work in my local hospital on the nurses' bank. I was an infection prevention nurse at the time, but I didn't earn very much money. The senior nursing management in the hospital knew I was an infection prevention nurse. So they had an elderly lady who was very ill, who apparently had salmonella food poisoning. So they had me for the whole shift, just looking after her. And I didn't have to do very much for the whole shift. They employed me for the whole shift just to look after this lady with salmonella food poisoning, who was highly infectious to everybody else on the old people's ward. At the end of the shift, the patient eventually fell asleep, and I came out of the room just before I went home. And just for 5 minutes, when I wasn't doing anything very much, I filed the laboratory reports, which came then to the ward in hard copy. They didn't come online in those days. And I looked at her laboratory form, and I looked at it, and I looked at it. And I said to the nurse in charge of the ward, do you realise that on this laboratory form, it says no salmonella present? So you've hired me for the whole day just to sit there and to do not very much. Nice things like that don't happen very often, but I earned my money the easy way that day. So gram-positive and gram-negative bacteria. It's a very important distinction, and it's worth remembering which bacteria fall into which group, because it's an easy way of remembering things. So let's have some examples of gram-positive bacteria. There is a genus of bacteria called Bacillus. I know that rod-shaped bacteria are called bacilli, but Bacillus is also a group of bacteria as well, just to be confusing. And they are rod-shaped. Bacillus forms spores. Bacillus anthracis is responsible for anthrax, which is an occupational hazard for people who handle hides and cure hides of animals. Clostridium is a species of gram-positive a genus of gram-positive bacteria that does form spores. Clostridium tetani is the organism that's responsible for tetanus. Clostridium botulinum causes a very rare but very dangerous form of food poisoning, and Clostridium perfringens also causes food poisoning. Corynebacterium, like Corynebacterium diphtheriae, that's the one that causes diphtheria. Staphylococcus aureus lives on the skin of about 30% of people, and it causes wound infections if it gets access into a wound. Streptococci cause sore throats, which are considered to be mild infections, and pneumonia, which is a severe infection. It can also cause severe wound infections and other kinds of infections. And we'll talk about staphylococci and streptococci in detail later. Gram-negative bacteria, some examples. Acinetobacter is one that you might or might not have heard of, often causes outbreaks in burns units. It causes healthcare-associated infections, particularly bloodstream infections, pneumonia, and wounds. Now, we've just said that gram-negative bacteria don't particularly survive drying very well. They never form spores. Acineta doesn't form spores, but just to be awkward, it does tend to survive drying out more than many of the other gram-negative bacteria. Bacteroides causes peritonitis, abscesses, and bloodstream infections if it gains access to those places. It isn't usually present there. E. coli causes healthcare-associated infections. It is the most common cause of community-acquired urinary infections. And often women, particularly older women, who develop E. coli infections in the community can be admitted to hospital, and then through cross-infection, they may develop endogenous infection, they may develop a bloodstream infection, which by cross-infection can be transferred to other patients. Klebsiella is a healthcare-associated infection, causes urinary infections, bloodstream infections, and wound infections. Very nasty organism. Pseudomonas, which you almost certainly will have heard of, causes healthcare-associated infections, urinary infections, bloodstream infections, wound infections. Neisseria is a gram-negative. It's responsible for sexually transmitted infection. Salmonella, responsible for food poisoning, cross-infection in damp environments. So it's not unknown for salmonella outbreaks to occur and never to be able to find what the source of it was, probably from food poisoning in the first instance, but then it can get into the environment and be spread in the same way that a lot of other gram-negative bacteria are spread. Vibrio, causing cholera, is gram-negative, and so is Yersinia, that causes the plague. Bacteria are also classified according to their ability to use oxygen. And facultate is a word that means ability or talent. You can see lower down the slide, we talk about organisms being facultatively this or that. I always have to think what the word facultate means. I always forget. It's not a word that we use very much. We have faculties in universities, or particularly universities in the US. Aerobic bacteria are those that are able to survive and grow in an environment where there is oxygen. And if something is an obligate aerobe, they must have oxygen in order to survive. Mycobacterium tuberculosis is often described as an aerobic bacterium, although actually it can survive in very low oxygen circumstances, although that doesn't occur very often, but you can get TB in other parts of the body beside the lungs. Anaerobes are bacteria that survive and grow without oxygen. A facultative anaerobe or aerobe is one and the same thing. It uses oxygen to support metabolism when it's got oxygen, but it can switch to anaerobic respiration if no oxygen is present. Staph aureus is like that. It can grow on your skin in the presence of oxygen, but if it gets into a wound deep in the tissues where there is no oxygen, it can still survive. Staphylococcus epidermidis is the same, and E. coli is the same. In fact, most human pathogens are the same. Obligate anaerobes are killed in the presence of atmospheric oxygen, and they have to use a different source of energy to respire. Bacillus fragilis, Clostridium perfringens, and Clostridium tetani are in that group. You think of all the folklore that surrounds Clostridium tetani, in which there's a grain of truth. And tetanus is an infection that occurs. It has to be inoculated deep into your tissues. You can't get tetanus just through touch. People often get tetanus as a result of gardening because they get a deep penetrating, that's the word, a deep penetrating injury on the end of a rose thorn or on the end of the tines of a fork. The spores of the tetanus have to be delivered deep into the tissues where there is no oxygen in order for them to survive. So there are clinical applications here. If somebody is very, very ill, and they're going to need the correct antibiotic as a life-saving measure, we take blood cultures from them, and we think that they might have a life-threatening bloodstream infection, and we set up two bottles, an aerobic bottle and an anaerobic bottle. If you go into the virtual laboratory, you will see that. You'll see a cupboard, and you will see the bottles where they've been inoculated, because time can't be wasted when somebody is that ill. We have to give them a broad spectrum antibiotic very quickly, but we hope to give them a very specific one, and we hope to grow the bacteria responsible and identify it as fast as possible. Virulence, the ability to cause disease, depends on the ability of the pathogen to survive. And bacteria vary enormously. The gram-negative opportunists, the ones that we call them opportunists because they take the opportunity to cause infection when they can. These are things like E. coli, Klebsiella, Pseudomonas, are not very pathogenic really. In a healthy person, they don't usually cause infections unless they get somewhere where they're not supposed to be. Whereas Treponema pallidum, which causes syphilis, can only cause infection in a very particular part of your body, and you can only get it in a very particular way. And Treponema pallidum is so fussy about where it will grow that it won't grow outside living tissues. If you want to grow the organisms responsible for syphilis in the environment outside the body, well, you can't do it. They have to be grown inside the tissues of a laboratory animal, generally a rabbit. The sexually transmitted diseases are very fussy about where they will grow. We often refer to them as fastidious organisms because they're very fussy. And it seems odd to call something which is rather shady fastidious, but it's one of the peculiarities of language. The other thing about pathogens is they have to reach the appropriate site on the host. Neisseria gonorrhoeae likes the cervical epithelium and the urinary epithelium. And in order to get in there and to invade, bacteria must have the necessary morphological characteristics. They must have the pili, or they must be able to produce enzymes or toxins that damage the host. Enzymes function as pathogenicity factors. Some bacteria release enzymes called hemolysins that break down blood cells. Staph aureus is like that, also streptococci and enterococci. Some bacteria produce cytotoxins that kill cells by destroying their proteins. Salmonella is like that. Collagenases are enzymes that destroy a protein called collagen. Collagen is present in connective tissue. Staph aureus produces an enzyme produces collagenase enzyme. And what happens is the collagenase causes protein to clot, and the bacteria manage to wall off the surrounding tissues. And they multiply in large numbers. Because the rest of the tissues are blocked off, then they're protected from phagocytosis. The white blood cells of the host can't eat them up. The bacteria multiply, and you get an abscess forming. I really do wish when we had the class like this that I could have a whiteboard and I could describe to you the formation of an abscess. It's a very nice thing to demonstrate to a class, particularly a class of young people who are still spotty, because a spot, of course, is nothing but a small abscess. So they're always fascinated in it. And it always goes down particularly well, if you want to demonstrate it, if you use a green pen on the whiteboard to represent the pus. In fact, generally a class of people enjoy seeing it so much, they want to see you draw it twice. So this is where being on PowerPoint online is not really so exciting or interesting. But some bacteria also produce enzymes. These are the ESBL group, the extended spectrum beta-lactamase bacteria. E. coli and Klebsiella are examples of bacteria that fall into those groups. It's important to mention them because they are important pathogens that cause outbreaks of infection globally, and they cause a lot of damage and, of course, cost a lot of money. They're things that make healthcare expensive. Some bacteria form a range of infections, and Streptococcus group A is among those. And it's abbreviated to GAS. And we always include this because people always talk quite a lot about gas, and they generally see it where they work. Streptococcus pyogenes, which is the causative organism, is gram-positive. It forms chains, and it's a hemolytic organism. It's carried in a lot of people's throats. The number of people carrying it depends on where they live in the population. It can be carried in throats, on skin, and asymptomatic carriage is very common. If people live together in large intergenerational households where there are children, people of working age, and then older people, you get a lot of carriage there. Some people tend to carry streptococci, and it doesn't matter how many antibiotics you give them, they tend to get it back. I think I'm one of those people. Down the years, I've had a range of infections, of throat infections. At one stage, I used to get eye infections, and they were streptococcal, and they could be treated, and I would get them back again. I don't live in an intergeneration household, but I've always had a lot to do with students and being in class with students, and I think probably I originally got them from students. I can remember one stage, a lot of people in my class had coughs and colds, and they weren't very well, and I was fine until I got a cold, and I started to get better from the cold. And then quite suddenly, I was very, very ill, and I had tonsillitis. And I suspect that I was carrying streptococci in my throat. And it was that caused an infection. In the spring of this year, I was very ill indeed, with a very bad chest infection that lasted for quite some months. I think it was a streptococcal infection. I don't actually know, because the GP didn't take any throat swabs. I know that in this life you should be, assertive, and you should be able to challenge people. But when you go and see the GP, and the GP is somebody that you don't know, and you don't feel very well, and in fact you feel terrible, you don't always feel in a challenging frame of mind. So I didn't say anything, although I should have done. I did receive the appropriate antibiotic. In fact, I have the fame of starting on a very heavy, large course of antibiotics the day they launched the new antimicrobial program in the UK, the next 5-year antimicrobial plan. I embarked on a large course of antibiotics, and I felt terribly guilty and fraudulent for requiring them, but I did get better. But streptococci can cause mild infections, although the person having the infection doesn't feel it's mild. It's responsible for the infection scarlet fever in children, for skin infections, impetigo, and for cellulitis, infection of the of connective tissue. It's a very common cause of community-acquired pneumonia. We vaccinate the under 5s, we vaccinate older people, and people are particularly at high risk at any stage of their life. People who've got liver conditions, cardiac conditions, and spleen disease, or people who've had to have their spleen removed. Gas can also cause wound infections, and some of them can be very severe. Necrotizing fasciitis, deep muscle tissue infections, that is the causative organism of those. And invasive infection, eye gas, is very serious and very life-threatening. And usually we have somebody these couple of days who's heard a lot about eye gas and wants to hear about it. Group A streptococcal infections became very common post-COVID, and they were talked about in the media then an awful lot. There was a big seasonal average increase in cases of pharyngitis and scarlet fever because people had been indoors, particularly children had been indoors and had no natural exposure to infection. So in winter 2022-23, there was a big increase in eye gas in children. And it became quite a big public health issue, notified cases to the UK Health Security Agency with early antibiotic treatment to prevent community spread among those at risk. Transmission, group A streptococci are transmitted by direct contact with nasal and throat discharge of somebody who's infected. So if somebody has got a nose and throat infection, it doesn't do to handle their bedclothes and certainly not the handkerchiefs that they've used, unless you really have to, and to clean your hands extremely carefully afterwards. And if you wear gloves, to make sure that you still clean your hands, because you can easily contaminate your hands. These infections most commonly occurs infection from people who are heavily infected. It's a good example of the bigger the dose, the bigger the infected dose, the bigger the risk. So prevention is generally good hygiene, good hand hygiene, and immunization of people who are at high risk. Exotoxins are produced by gram-positive bacteria. People often say, well, when you have an infection with bacteria, what is it that makes you ill? And it's the toxins the bacteria produce. Exotoxins are released outside the cell. The prefix exo on a word means outside. So exotoxins are produced outside the bacterial cell. They escape from the bacterial cell into the extracellular fluid, where they dissolve and they're carried throughout the tissues. They destroy host cells and they inhibit specific cellular functions. And they are among the nastiest things that occur in the living world, and they can be lethal. A good example is Clostridium tetani. The tetanus toxoid is a neurotransmitter. It affects neurotransmitters. It affects the neurotransmitters in the central nervous system. First of all, it affects the neurotransmitters in your jaw, and you can't move your jaw, you can't speak. That's the accounts of the old-fashioned word lockjaw. And if that isn't bad enough, then it affects the nervous impulses in your lungs. You can't breathe. If somebody has a tetanus infection these days, then of course we can ventilate them. But years ago, when that wasn't possible, C. tetani inevitably was a fatal disease. It's very severe. We very rarely see it in this country, because although we have lots of examples of public health failures and we beat ourselves up about them, some of our public health initiatives are successful. Immunization is available for tetanus, and it works. You don't very often hear of anybody having a tetanus infection. I've never seen anybody with a tetanus infection. Somebody that I talked to came from the Far East had seen a tetanus infection, and somebody who lives in the next road was at school with somebody who got a tetanus infection, and it occurred quickly. One day he was off school because he wasn't very well, and the next day he was dead. But that, of course, is rare and something that you certainly isn't necessary in the UK these days. Excuse me, I'm going to cough. Staph aureus causes food intoxication. If you eat food that's contaminated with Staph aureus, maybe from pus on somebody's finger, you will become ill very quickly, and you will have what is described as mild diarrhea and vomiting. But the people who have it generally don't describe it as mild. They generally say they feel very ill. If somebody says to you, oh, I felt very ill very quickly after I ate something, and I didn't know whether to sit on the loo or vomit down it, then almost certainly it's Staph aureus food poisoning that they had. It's not a genuine infection. If one person has it, it's caused by the toxin, they can't give it to another person. A genuine infection, the bacteria would have to multiply in your stomach long enough to cause an infection, but within 6 hours, people generally get a toxin infection. And the toxins are, of course, very heat stable. You can't get rid of them by heating food up to a high temperature because you'd incinerate the food, and the toxins would still be left. But if I have Staph aureus food intoxication, I can't give it to you. But if I have pus on my finger that contains live Staph aureus bacteria and you swallowed it, you certainly could get a food intoxication, which is why, of course, we tell people who work in catering that they must cover up sores and boils and what have you with a plaster that's water resistant, so they can't transfer any of this on. Bacillus cereus is a rod-shaped bacterium that causes special fried rice food poisoning that has a particular predilection with Chinese food and Chinese takeaway meals. Bacillus cereus lives on plants, particularly it's associated with rice, particularly cereals, hence the word cereus. So what happens with Bacillus cereus food intoxication is the bacteria are there, the spores are there in the rice. They can't harm you. The spores are not going to do anything to you if you under normal circumstances. But what happens with special fried rice is people in the shop boil the rice overnight. They boil the rice, and then overnight they store it, usually in a warm place. They don't refrigerate it. The next day they make special fried rice by frying it at a low temperature. Of course, when the food's not refrigerated, the spores hatch out. You get a big dose of vegetative bacteria growing. Frying the food at a very low temperature doesn't destroy them. And the person who comes along and eats the special fried rice then gets a very nasty dose of food intoxication. They're not infectious to other people, but they don't feel very well. If you spend very much time listening to me, I will put you off all the food you've ever eaten. So don't pay too much attention to me, of course, but think very carefully where you're going to eat special fried rice. It's safer to stick to boiled rice. Clostridium botulinum, I talk about not because I think you're going to see this infection, but because we've now been going a long time, and it's quite nice to hear about something unusual to wake us all up. Clostridium botulinum, the spores are found in fruit and in vegetables, seafood, a wide range of foods. The bacteria grow in low oxygen conditions, because Clostridia do, and they produce the toxins under anaerobic conditions, and they are among the most lethal toxins known. And there is a risk when food is improperly bottled at home. I don't know anybody who tries to bottle food. It's quite an old-fashioned thing to do. But the toxins block nerve function, and they affect the respiratory and muscular parts of the body, and they cause respiratory and muscular paralysis. Infection is very rare, but it's life-threatening unless you can get to the person and ventilate them very quickly. The biggest outbreak that we had in the UK was related to hazelnut yogurt, a peculiar foodstuff to be associated with food poisoning. I can remember this outbreak because I can remember when it was headlines in the newspaper. 27 people became ill and there was one death. But it was notorious because we hadn't had an outbreak like this in the UK for a long time. Recent outbreaks, we do get recent outbreaks of Clostridium botulinum. Somebody in the States home bottled peas in 2019, and there was an outbreak to do with that. But I don't think anybody died. And then there was a case last year with bottled sardines from a restaurant in Bordeaux in France. I suppose they had a glut. They had a lot of a ship bringing or boat bringing in a lot of sardines. And so they bottled them up and stored them. So outbreaks aren't unknown, but we don't get as many of them as we used to. Quite often when you buy food, it's vacuum packed. The vacuum pack means that the food is effectively in a sealed environment. And one of the things that's designed to prevent is botulism. Clostridium botulinum does have commercial importance, of course, because it's what they use to make Botox, which is used to treat people with illness as well as cosmetically. The gram-negative bacteria produce endotoxins. These are part of the bacterial cell wall, and they're released when the bacteria die. And they're what? And when the bacteria die is when you begin to feel the symptoms of fever and malaise, and you begin to realize that you don't feel very well. Examples of endotoxins are the ones that are produced by Salmonella typhi, which causes typhoid, and Neisseria meningitidis, which is one of the causes of meningitis. Bacterial growth requirements, we can use this and has clinical applications, and we can do a lot towards preventing infection by keeping the clinical environment clean and dry. Some technological things cost a lot of money, including to do with infection prevention, but keeping the environment clean and dry doesn't really cost very much at all, but it helps eliminate cross-infection. Some wards these days are designed as waterless wards, where they have sinks away from the clinical areas. Splashing in an intensive care unit or a neonatal unit, the water coming from the drain in the sink might be heavily contaminated, particularly with Pseudomonas, which likes to grow down pipes. And then splashing can contaminate the environment around the sink. It can contaminate people's hands, and then you can carry that, if they're clinical people, carry it to the patient. But if you ban all the sinks to non-patient areas, to sluices and kitchens, then you can do a lot to prevent outbreaks of infection on wards. And you can purchase self-disinfecting sinks as well, ones that heat up or pour chemicals down themselves to destroy anything that might be living down the U-bend. Bacteria also must have an energy source. They must use oxygen or another substance. And we've said that that's very important for culture and diagnosis, particularly when people are very, very ill. Bacteria like to live at a particular pH as well, and that influences the distribution of the normal flora. If you eat a big dose of bacteria on salad vegetables, which you may very well, it doesn't usually matter, because the pH of your stomach, the hydrochloric acid in your stomach, has a pH of 2, and that destroys bacteria. But a large proportion of people these days are prescribed antacids, and these people are at greater risk of infection, gastric infections, because they're not producing hydrochloric acid. So when we give people antacids, that's one of the things that we need to remember. Bacteria like to grow at a suitable temperature, and pathogenic bacteria, by no great coincidence, like living at the same temperature that we do. Most pathogens that operate as human pathogens like to be at 37 degrees centigrade. And hospitals, remember, are warm as well as damp, and so are nursing homes, and so are hospices, and so they're very likely to be places where bacteria multiply and reproduce in large numbers. There are bacteria that survive at very high temperatures and very low temperatures, but they don't usually behave as human pathogens. I don't know very much about them because they're not usually something that I have to worry about, or that we do have to worry about in hospitals. There are bacteria that will survive in boiling water, but you're not going to give anybody boiling water, any person. You're not going to give it to them to touch or to drink or to have anything to do with, not directly. And so the bacteria that can survive boiling are not going to affect us. And of course, bacteria need to be protected from ultraviolet rays. One of the things that we do when we hang clothes on the line to dry is that we're killing the bacteria as well as drying them in the sun. Bacteria reproduce. We've said that this is one of the characteristics that they have, and they pass on their genetic, their genes to their offspring. The way that bacteria reproduce most of the time is that they quite simply split in half. So that's asexual reproduction, which doesn't sound very exciting, just splitting in half. So there's a parent cell, and when the parent cell splits in half, there are two progeny, two daughter cells. They get exactly the same genes that their parents did. So there's no change for evolution. Those cells behave exactly the same way that their parents did. They can't behave in any different way. So that's simple binary fission. And when bacteria reproduce, they can do so every 30 minutes. Under warm, damp, optimal conditions, you can easily get a big reservoir of bacteria in 30 minutes. This has clinical implications when we take laboratory specimens. If you take a urinary specimen and you don't send it to the laboratory quickly enough, or if you don't refrigerate it, then if there's a contaminant in that specimen, it can reproduce in very large numbers. So by the time it gets to the laboratory, it's going to be there, it's going to be in very, very large numbers, and that's going to make the work of the technicians in the laboratory that much more difficult, because that's one of the diagnostic symptoms of having an infection. So they have to look very carefully to see if they can see any pus there. So it's one of the reasons why we write on a laboratory form what signs and symptoms the patient has got. But you could waste a specimen that way, or you can make life very difficult for the people who work in the laboratory. But by the same token, you've got a very big reservoir there that the people in the laboratory are going to be exposed to, or if the specimen leaks, or if it gets damaged in any other kind of way, or if it gets sent through the post or whatever. So there are clinical implications there. Bacteria also reproduce sexually, which most people don't realize. And this occurs via the plasmids that Chris was talking about earlier. A plasmid is a small extracellular piece of DNA. They live in the cytoplasm and they carry their own genes, and the genes on the plasmid are able to respond to environmental fluctuation. The plasmid is extrachromosomal, and if a plasmid spreads throughout a population of bacteria, then they can convert a whole population of bacteria to behave and to have characteristics that they didn't have before. Plasmids often carry the genes for antimicrobial resistance. So what happens is that two bacteria get together, and the plasmid travels from one bacterium to another in a very passive kind of a way. And this mostly occurs in gram-negative bacteria, but it can occur between different species of bacteria. So think, this is quite horrific. Think of a cat mating with a dog, and you've got some idea of how plasmids can spread through a population and convert it from a population that wasn't antimicrobial resistant to one that was. Once I was standing up in front of a class of people, and I started to talk about bacterial sexual reproduction, and somebody said to me, well, why do they bother to do it? I mean, if they can just split in half, why do they want to be bothered with the other way? Why do they need to go to the trouble? I'm very seldom bereft for words, but I couldn't really think of the words, there. I said, well, I suppose it's supposed to be fun, and maybe it's fun for bacteria as well. But certainly they do undergo a kind of sexual reproduction. They do transfer plasmids, and plasmids often carry the genes for antimicrobial resistance. And that is how you get antimicrobial resistance sweeping through a population of bacteria. And you don't have to start off with many that are antimicrobial resistant in the first place, not with something that can reproduce and form a great big reservoir every 30 minutes. So you get conjugation, you get the transfer of a plasmid with a gene for antimicrobial resistance, you get a new superbug, as they're often called. The superbug divides every 30 minutes, you get a big reservoir. And you can see that this is a huge public health risk. A good example of this are the extended spectrum beta-lactamase, the SBL bacteria. The beta-lactamase enzymes are produced by bowel bacteria, usually E. coli or Klebsiella. The SBL bacteria are resistant to many widely used antibiotics, including ones that we prescribe very often: penicillin, cephalosporins, trimethoprim, tetracyclines. These infections then become very hard to treat. We have a global health challenge. Outbreaks have occurred in neonatal units, in intensive care units, and these outbreaks are plasmid mediated. The carbapenemase-resistant bacteria, the CREs, are the ones that are resistant to the carbapenems. These are antibiotics that bind to protein and prevent the synthesis of the bacterial cell wall. The carbapenems tend to be very well tolerated by patients, so we use them very widely in clinical practice. And they cause resistance occurs particularly among gram-negative bacteria. And this is a growing major public health crisis as well. And again, resistance is transferred by plasmid. An outbreak has been described this year from the Far East in a pediatric ward. The source was traced to a ward sink where a lot of splashing went on, presumably because the bacteria were growing down inside the U-bend where we can't reach to clean them. Several species of gram-negative bacterium were involved, including E. coli and several species of Klebsiella, and there was transfer between the species with plasmids. The outbreak was controlled by very strict hand hygiene, disposable tools for cleaning out the sink to make sure that it was running properly, and disinfection of the sink with hydrogen peroxide, and limiting items that came near the sink. For example, if you've got a sink in a clinical area, you shouldn't use it for emptying flour water down or water in people's glasses or cups. That should go on in the kitchen. A sink in a clinical area is to be used for staff hand hygiene and not for other purposes. So if we need a short break, we can have one now, or we can carry straight on. We can do whatever people feel they would like to do.
I'd carry on if you're happy to as well.
Yeah, that's fine.
You okay?
Yeah, I'll have a quick drink. So let's apply the chain of infection. Let's have some examples that we can plug into the chain, and we can see how it works. So let's apply the chain of infection, Staphylococcus aureus. Staphylococcus aureus lives on people's skin, about 30% of people in the population, and it's spread by contact between surfaces, direct contact on hands, or between fomites like bedpans, bedclothes, toys in a children's ward, and it gets in through broken skin. It has many virulence factors that we've described, like the hemolysin enzymes, and it is prevented by good hand hygiene, environmental decontamination, keeping the environment clean and dry, decontaminating shared equipment, and using disposable equipment when we can to avoid fomites. So Staphylococcus aureus, examples of infection that it causes is bacteremia. When people talk about sepsis, they're talking about bacteremia, bloodstream infections. It can also cause pneumonia, endocarditis, which is inflammation, infection of the membranes lining the heart, and osteomyelitis, infections of the bone. Antimicrobial resistance can occur, MRSA infection, or we can have vancomycin-resistant Staphylococcus aureus. So Staph aureus is prone to antibiotic resistance, but remember that any infection caused by Staph aureus can be very severe, irrespective of whether it's antimicrobial resistant or not. So it doesn't have to be antimicrobial resistant to cause a severe infection, but if it is antimicrobially resistant, then that infection is even harder to treat than usual. So that's Staph aureus. Let's think about Salmonella enteritidis. Salmonella, we've said, is a flagellated bacterium. It's gram-negative and it doesn't form spores, and it's responsible for outbreaks of food poisoning. It causes those in the community, in things like the restaurant industry. It's also associated with big outbreaks, or has been in the past, responsible for big outbreaks of infection in hospitals as well. In the early 1990s, there was a big outbreak of infection in St. Thomas's Hospital, but you wouldn't have read about it at the time because people in St. Thomas's Hospital didn't speak to the press. The reservoir of Salmonella is that it likes to live in contaminated food. It can be spread to patients who can then act as a reservoir. Health workers can carry it, and also domestic and wild animals often carry Salmonella. Exotic pets, where people keep pythons or lizards, for whatever reason, quite often apparently they're contaminated with Salmonella. I don't know why, but if you have those animals and you touch them, then you should clean your hands very carefully afterwards. A lot of people think that a snake is a slimy thing to touch. Actually, it's not. It feels quite nice. It feels quite nice and warm, not warmish, coolish, and quite dry if you feel a snake. I quite like the feel of a snake. I haven't got one. I like things, pets. I like a cat or a dog that you can cuddle. But I can't really see the appeal of something that's not very affectionate to you. But some people like to keep them, but if you do keep them, you need to clean your hands carefully afterwards. So the portal of exit out of your body, if you're carrying Salmonella, is in vomit, in feces, and contaminated hands will contribute to spread. The mode of transmission is contact with vomit, feces, hands, fomites, environment that's contaminated, particularly if you've got somebody who's not continent, contaminated food. The portal of entry is the gastrointestinal tract. Salmonella is quite a nasty organism. It's virulent, it's quite aggressive. It can survive quite a long time on your fingers. It can survive about 30 minutes on your fingers. So if you have dealings with anybody like this, you need to wash your hands very carefully. So prevention is very good hand hygiene, environmental decontamination, because it can build up big reservoirs in the environment. Public health measures are good food hygiene in places where food is manufactured and served, tracing sources of outbreak when they occur. Infectious diarrhea is a notifiable disease to the health authorities. If you have somebody has a salmonella infection, do you put them in a single room? Well, if you've got enough single rooms, most certainly you do. But in this country, we are unusual in the UK. We do not have enough single rooms for our needs, remembering that not just infected people need to go in single rooms, but also people at the end of life, people who are patients who are aggressive, patients who've got all sorts of things wrong with them, all sorts of other things, patients who are behaving in an antisocial way. We like to put them in a single room, noisy people that are going to keep the ward awake. In other countries of the world, in most countries, they have a far higher proportion of single rooms than we do. And in many countries, I think probably the majority of countries, people are automatically nursed in single rooms. But in the UK, where people are particularly shy, especially about illness, we tend to put people all together in wards. We don't have enough single rooms, and those that we've got don't always have en-suite facilities. So we can't always isolate our infectious patients the way that we would like to, or that we should. So sometimes you have to do risk assessments. Sometimes you have to make very difficult decisions about who you're going to put in single rooms. There's a policy initiative in the UK to build future hospitals with a much bigger single room provision. But how soon we're going to have new hospitals and how soon they're going to replace the ones that we've already got, or we're going to upgrade the ones we've already got, is anybody's guess. But building design does have big implications for infection prevention, and when hospitals are commissioned, then infection prevention specialists should certainly be involved. Now let's apply the chain of infection to Neisseria gonorrhoeae. Neisseria causes a sexually transmitted infection. The reservoir is infectious people, but particularly in asymptomatic women. Women are usually asymptomatic because where the pus is, where you see it, is on the cervix, and people can't visualize their own cervix. Men, it's the urethra that is where you will see the pus. Somebody seeing that will realize that something is wrong, and they'll do something about it. But women form a big reservoir. There are nerve endings in the cervix, but people don't generally feel as much discomfort. Women don't generally feel as much discomfort as a man would. The portal of exit is in urogenital secretions. The mode of transmission is sexual, and the infected birth canal. Remember that I said to you that babies can pick up an infection in their eyes that is gonococcal as they pass through the birth canal, and that condition is called ophthalmia neonatorum. And of course, it is a notifiable disease to the public health authorities. The portal of entry into the body is the urethra, vagina, the anus, and the conjunctival epithelium. I've been talking a long time now, you can tell. Prevention is good public health measures, education, contact tracing people, educating people about the dangers of sexually transmitted infection, persuading people to come forward if they think that they might have run a risk, and to come and be tested and to be treated. And treatment in this country is free of charge, and the antibiotics are free of charge, even for people who generally would pay for their medication. And clinics offer confidential help. Clinics offer a great deal more help and are a far better place to go to than your GP, because GPs are generalist and clinics specialise in the treatment of sexually transmitted disease. Bordetella pertussis, whooping cough. We've had a lot of cases of this in the UK in recent months. There was a big upsurge in 2024, and the antibiotic that is usually used to treat it, erythromycin, was in short supply for some time in the UK. It's a gram-negative aerobic coccus. It needs oxygen. The reservoir is the human respiratory symptom. Transmission is person-to-person spread, and the bacterium can survive in the environment for a few days. So it can survive for quite a long time. It's quite a tough organism, unlike Neisseria gonorrhoeae, which doesn't survive very long in the environment. And there's possible fomite spread as well. Whooping cough is most infectious in the first few days before you know that the baby or the child is likely to be infectious, but they are infectious for up to 5 weeks. Whooping cough can be a very dangerous childhood disease It can go in susceptible children. It can lead to pneumonia, encephalitis, to seizures, and to dehydration. It can cause severe illness in adults if you get it in adulthood, and treatment is erythromycin or tetracycline. But there was a shortage of erythromycin in the UK in the earlier months of this year. Prevention is by childhood vaccination and by vaccinating women antenatally. The antibodies can cross the placenta and protect the baby. So whooping cough is potentially preventable, but not everybody is vaccinated. And so that's an example when vaccination doesn't work. Now, what we can have here, I'm just going to quickly look at the next slide. So here, we are going to have a break out, is I would like people to think about a pathogen that you get where you work that causes problems and that has the potential to cause problems. Think about what the problems are in your group and what the potential problems are going to be. Apply the chain of infection, and what we'll do on the next slide, I'll show you a template for feeding back. And so from that, we'll identify lessons for future clinical practice, policy, and education in your organisation, remembering that you all work in different organisations. Now, we're getting to the end of the morning now, so I think we should just take 5 minutes for this if we go into our groups for a few minutes.
That's great, Dinah. Do you want them to feed back, or are you going to?
We could feedback. Do you think we could feedback quickly?
Yeah, we'll do feedback as a
If
whole
everybody
group.
chooses something different, it's going to be a bit difficult for me to
Yeah.
do feeding back. But I think in the feeding back, we should think about the clinical setting, the name of the organism, the clinical problem, the reservoir, the mode of transmission, and the portal of entry. We haven't got much further to go now with this lecture.
No, you're doing really well. How did you guys get on? I bet nobody looked at what group they were in, did they? Okay. Group 1, we had Angela, Betsy, Karen, Nikki, Nana, and Reza. So what organism did you choose?
Betsy, you all right to read off of your
Yeah.
notes?
We discussed C. diff.
Lovely.
So just through the chain of infection, obviously the organism C. diff, we said the reservoir would be in your gut. The portal of exit would be through the diarrhea that the infected person is excreting.
I was about to say lovely again, but I don't think that's the right word.
The mode of transmission, so through contaminated surfaces where the spores have landed. So fomites, that was the right word.
Yeah.
So through contaminated hands, so indirect and direct contact. And the portal of entry would be through your mouth, so the fecal oval route.
Yeah.
And then so susceptible host, I would have thought anybody anybody in hospital, unwell. I think that's it. I think that's everything we mentioned.
Lovely. What about prevention? Hand hygiene.
Oh yeah, so to break the chain, so hand hygiene, wearing your PPE, isolating that patient so they're not expelling the diarrhea all over the environment, and making sure we're cleaning the surfaces and the environment and the equipment used.
Isolating them if you can within ensuite facilities, if you've got them, if you possibly could, but particularly incontinent patients. And avoiding broad spectrum antibiotics if you can, but you can't always do that. So that's very good, very, very promising indeed. Very nice. Well done.
Thank you. Group 2, we had Anik, Kirsty, Manisha, Monica, and Suzanne. Anybody like to speak for group 2?
All right, I'll go. So we looked at MRSA in a patient who had a surgical procedure done. She had appendectomy. A week after she started producing pus, and when they did the swab of her wound, she had MRSA in there. Previously, the patient did not have MRSA. So we know that MRSA is skin to skin contact or contact It could be on any of the surfaces, possibly in theaters or when she went to have her dressings done. In terms of the reservoir, as I said, it could be could be like instruments that they've used, but usually in theater it would have been cleaned, sterilized. So next best area probably would be when she goes to have her dressings done, because if the nurse is there and she's having multiple patients, even if she does hand hygiene a lot, there could also be the possibility of the trolley or whatever she uses to do the dressings, probably that area is not cleaned properly. Portal of exit would have been the wound because it's producing a lot. And it could, as I said, MRSA could live on our skin. What am I missing? Susceptible hosts. The fact that she had surgery, or anybody who has surgery, or any vulnerable patient, cancer patients would have had, could possibly have the infection. Yeah, that's what we didn't get to finish, but that's what we had an idea of in terms of.
This was a real patient.
Yeah, it was a real patient.
Yeah, recently.
Yeah, recently.
Well, MRSA infections still exist, and we still shows that we still have to talk about them on the course. I update the lectures, but there are some things that we still got to talk about. It's very good. Thank you very much.
Thank you.
Thank you. And then group 3, we had G Wood, Marie, Marietta, and Stacey. Anybody like to give us any feedback?
We also spoke about MRSA.
Are you going to speak, Marietta?
No, you're gone. It's gone. It's okay. Carry on.
Okay. So we discussed MRSA. We discussed a patient that had a long lie in hospital, that had gone into hospital with a pneumonia and was discharged back to our facility with MRSA. She had a wound on her leg. She had quite edematous legs, and came back with dressings to that area. She came back with treatment. Very little information. We did try to find out. The reservoir being the wound on her leg. The chain of infection could have been that she's acquired it through changing of dressings or poor hand hygiene. The exit was that it was very wet, very pustule. There's a lot of pus. People at risk, the hosts, the staff on the unit. What did we do? We used effective PPE, increased hand hygiene, increased cleaning of the room. She was lucky enough to have ensuite facilities in her own room. But we did go on to, we were just about to discuss, one of the people in the group was discussing how lessons were learned from that and what did we do. And she mentioned PR meetings, but then we got cut off, so we couldn't continue. So it was interesting to want to hear what she had to say, but unfortunately we got cut off, so we might be able to pick that up in the chat.
Let's hear it now then. And we've got a couple of minutes. You're mentioning the PIR,
yeah.
post-infection review.
Infection review, yeah. So it's started to talk about that because we've had a couple very much recently within our areas from our different providers. And I suppose previously, as commissioners, we facilitated the PIR meetings and we generally chaired them, but under the new patient safety guidance, we're kind of reviewing that at the minute. But having said that, we've just had 3 PIR meetings, and we brought the providers, and if there have been other providers involved. So we brought wherever the patient has been identified as having MRSA, and anybody else who's part of that patient's journey around the table to have that discussion in relation to that learning, how it's identified, lessons that have been missed. And often, we normally then end up with talking about that a portion of where the initial infection will have been identified and will potentially have been contracted, because we know that there's still that financial burden in relation to the provider organisation and I'll use the term fine, really. So that is often part of the agenda as well. But I mean, certainly the meetings that I've supported and chaired have been really, really effective and been very productive in relation to that element of communication. So for me, when Marie was talking and giving her example, I was really concerned that communication hadn't gone across to Marie's organisation, and then be prepared in relation to not only the patient and their family, but also their own staff as well, and that duty of care. So yeah, I was just asking Marie whether that happened within their areas.
So no, but that's great that you've brought that to me, because then I can go back to our health protection agency, because what did happen was the questions were asked. How long had she been in hospital? What hospital had she been in? They did their tracing, but then we don't get any information from that. They don't come back to us after that, which again would be very, very useful for us. So thank you for that.
That feedback loop is really important.
Yes. Yeah. There's a lot there you can get out of that. Thank you very much indeed. Okay, should we come out of them?
Okay.
Yeah.
So thank you for that. Clearly, those discussions have been very, very helpful. I know there's some of you that have a lot more knowledge already about microbiology than others, and it's been really great that you've been able to share some of your experiences. As I said at the beginning, this is all about sharing with each other. So thank you, Dinah. Does anybody have any burning questions for Dinah? We have Dinah here tomorrow anyway. So if there are any that you think of overnight that you thought, oh, as you sort of assimilate the information, I wanted to know about this or I wanted to know about that, we have Dinah with us tomorrow.
We'll have more time tomorrow as well. It won't be quite so packed. We won't have to rush so much tomorrow.